Chapter 11. Before I do that, you guys, the recording from Friday's class didn't get up because there was a glitch in the uploading here. So it's being converted again now. We're trying to do it during this class, so hopefully it'll be uploaded later today. But that's why you have not seen Friday's if you were looking for Friday's recording. And then we'll get today's recording up as soon as we can. It takes, after the end of the class, to convert it into a file that we can upload onto YouTube. It takes hours and hours and hours. Pete looked at the one from Friday, and it was saying it was going to take 16 hours to convert. They don't always take that long, and then it didn't convert after all. So it's not a super quick process, so that's why they don't get uploaded immediately, and oftentimes not until the next day. But we'll still try to get those up as soon as we can. I have had a few people message me or email me when they're looking for a recording and they can't find it. Wait till the next day because you're probably not going to get it the day of the class. But if you're not getting it, let me know because we didn't realize until I had a couple people let me know that Fridays didn't ever convert. So I have no problem with you getting a hold of me and letting me know. And everything. How are the end of chapter tests working? I haven't looked at the scores. I get emails when you guys have been taking them, but is the process working okay? Okay, have no issues with that at all? Okay, so today's chapter 11. We're actually going to go through only part of the chapter today, and then you're going to get the rest of the chapter on Wednesday. And then Wednesday, you're also going to go over the introduction to the hands-on skill for the supraglottic airways. So my plan is today to hit the chapter up until when it starts talking about the supraglottic airways, and then I'll stop, and the instructor Wednesday can do the lecture portion of the supraglottic airways, and then do the skills introduction. So my hope is that I don't have to keep you here all 3 hours today, but we'll just have to see how it works or how it goes. Thank you. It was nice seeing you. All right, we're going to start with just a real quick anatomy review. I know we talked about this Monday when we kind of went through the entire body systems when we hit the anatomy of all of these. This will be a little bit more specific just to the airway and respiratory system. But again, they divide the airway into upper and lower airways. And what separates the uppers from the lowers? Larynx. The larynx is kind of the separation, okay? Then we're going to be talking about, how the whole ventilation system works. Some terminologies, specific to, is it respiration, is it ventilation, or what are the specific things? There's a lot of structures involved in facilitating oxygenation and ventilation. So what are the major structures in anatomy that have an effect on oxygenation and ventilation? Basically, what are the major components of the airway system? Okay, you got the lungs. How is the air going to get in and out of the chest? Okay, so you have your airways, but then you have the musculature that has to work to get the lungs to function properly. So you have your diaphragm, your chest wall muscles. You actually have the thoracic cage that all has to be, functioning appropriately, because if you have a problem with the actual cage, the bony structure, as you guys know from trauma, if there's a major chest injury, it's going to impair ventilation just from the cage not working appropriately. Then we've got the nerves and impulses coming from your brain and spinal cord, and then all the chemo receptors and stuff. All of that has to be functioning appropriately to allow for proper airway and ventilation. Okay, so your upper airways, again, I'm going to pass over some of the pictures. The upper airways was above the larynx, but what is the purpose of the upper airways besides just getting the air into the body? Okay, moisture, warmth, and filters it. It does all three of those. Now, most of that's going to take place if you're breathing more through the nasal cavity than your mouth. Because does your mouth filter it very well? Nope, it doesn't have all the hairs and stuff that are in your nasal area to help filter out the particulates. And your nose does a lot better job also of adding moisture to the air with how it goes to the turbinates and stuff, and the air gets all circulated and mixed up. It adds more moisture to it there. If you're primarily a mouth breather, you're not going to get quite as much of those benefits as if you're breathing just through your nose. All right, we talked about the larynx, dividing it. Okay, the pharynx, just a term kind of letting you guys know what structures are where, but the pharynx is your nasopharynx, so your nasal cavity, your oral pharynx, your mouth, and then the laryngopharynx, which is the lower part of your airway, or it's still upper airway, but it's the lower part of your upper airway between the larynx and the oral pharynx. All right, here's just a picture identifying all those different components. Okay, so now we'll talk specifically about those three areas within the upper airway. So the nasopharynx, it is mostly formed by the union of a lot of the facial bones that are in that part of the face. Okay, there's also cartilage and other things that kind of make it up, but it's that union of the facial bones divided by the septum. And again, it's lined with a ciliated mucosal membrane. And what is the point of that? When we talk about if it's ciliated, we talked about ciliated cells. What do those cells have? Those little hair-like structures, right? So it's lined with a membrane that's got this little ciliated cells, so it'll help trap the particulates. And it has the turbinates. And the turbinates are the things that they increase the surface area of the nasal cavity and also disrupt the airflow, mix it up to allow for that moisture to be added to the air before it goes down into your airways. And then your sinuses themselves. Okay, the oral pharynx is basically what we're talking there is just your oral cavity, your mouth. And then that travels down to the epiglottis. What is the purpose of the epiglottis? It does protect the trachea. So when you swallow, it flaps back and forth between closing off basically the trachea versus the esophagus to make sure that we're not getting food and stuff down into our trachea. It flaps over and protects the trachea while you swallow. What is a medical condition that is specific to the epiglottis?
Epiglottitis.
Yeah, there's probably more than one, but the one that comes to mind is epiglottitis. Now, you don't see a lot of epiglottitis. I mean, I've only seen a couple cases in my entire career, and it's usually children that you see it with, but it's a super scary medical condition because the epiglottis itself can get really, really, really swollen, and just with it swelling, what can that cause? Just because of its location. Yeah, airway obstruction. And then the bad thing with epiglottitis as well, when people are suffering from epiglottitis, if you disrupt it, if you touch it, if you manipulate it, you can make the swelling get profoundly worse really, really fast. So in our world, if we have a patient that's having difficulty breathing and they're struggling, it's like, man, we got to protect their airway. We need to get an airway in. If you don't get that airway in right away, and you disrupt that epiglottis, you might not get a second chance. It can get that much bigger that fast, and they can completely occlude the airway. So typically, if you know it's epiglottitis, which sometimes we may not know, but if you know for a fact that that's what it is, it's better not to mess with the airway at all unless you absolutely have to and just transport them to the hospital. Okay, so we talked about the thyroid and cricoid cartilage Monday, but that kind of is basically where you think about with the larynx. Again, the thyroid cartilage is a big, thick cartilage at the top of the airway, and it's more commonly referred to as what? Or the lay term is the Adam's apple. It's that big thing you can feel in your neck. Then you have that thyroid cricoid membrane, and then the cricoid cartilage below that. And just keep in mind that glottic opening is the narrowest part of an adult airway. All right, so the air came in now. It went through either your nasal pharynx, your oral pharynx, down, through the into the trachea. Now we're going to get down to the lower airway. So we're below the larynx now. So what is the first structure of the lower airway that the air is going through? Trachea, okay? And then the trachea is going to break into different sides. So you're going to get your right and left, but then they'll start terming those different. So what are some of the other terms of the airways? So when it breaks, it's the bronchioles. So it goes trachea, bronchioles, and then bronchioles as they get smaller and smaller and smaller. When it breaks off into your right and left, though, does it break off evenly in between those two? Nope. Which is a sharper turn? It's a sharper turn to get into the left. It's more of a downward slope going into the right lung. And that's why when you hear, when the medics are intubating people and we get it too far, we usually get it into the right main stem, because it's easier for it to go to the right than to take the sharp turn into the left. Okay, so what is the purpose of the lower airways? Other than not just the entire lower airway, not just the tubes. So we're getting air into what? Into the lungs, into the alveoli specifically, and then really the ultimate purpose is to get oxygen clear diffused into the circulatory system, and to get the carbon dioxide removed from the circulatory system as well. Okay. All right. So we talked about the bronchioles being the smaller and smaller tubes of the airway. What are those tubes made out of? I mean, they're cells, but they're muscle cells. What type of muscle?
Smooth muscle.
Smooth muscle. Okay. Why do those need to be muscular? Do they stay the same, the size all the time? No, they're getting bigger and smaller depending on the demand of the airway system. So they are musculature and they do physically change. So when might be an example of when those muscles constrict or they're closing off the airways when you don't want them to. An allergic reaction, for example, is sometimes when those airways, those muscles constrict, but you really don't want them to constrict. But just remember that they're not just like a garden hose. I mean, it's actually a structure that will open and close itself, okay? And then the smaller bronchioles branch into the alveolar ducts. At the end of the alveolar ducts are the alveolar sacs, which are basically where the gas exchange occurs with the blood. All right, so you guys remember how the oxygen gets from the alveoli into the capillaries and how the capillaries the carbon dioxide gets from the capillaries into the alveoli? Yep, it's a diffusion. So does that require like a carrier molecule or anything to happen? In that case, it doesn't. It just diffuses across the membrane all by itself. It doesn't require anything to grab onto it and pull it across like some cells require. Again, there was those certain cellular activities where it has to have like a certain protein or certain carrier where it holds on to whatever it's taking across that cellular membrane. In this case, it's just diffusing across the membrane all by itself. So it doesn't require anything else. It just has to be in proximity to be able to diffuse across. That doesn't mean that there's not problems sometimes with the oxygen getting diffused into the capillaries or problems with the carbon dioxide diffusing out. There can be mismatches there where it doesn't work, but it's not because you're lacking a certain chemical or something. It's just because usually it's due to fluid or some other problem. But it doesn't require anything else. It's just diffusing. All right, now your alveoli do have surfactant that line the surface of it. And what is the purpose of surfactant? Why do we have that? It's purely just a lubricant. That's all surfactant is. It's a lubricant. But it's to keep the alveoli open. Again, we don't want them closing. We don't want them getting stuck together. We want to keep them open all the time. Sometimes if those alveoli start closing up, they will actually like adhere to themselves, and then they don't want to pop back open. So the surfactant helps that. Now, there are some medical conditions where they lose the surfactant, or there's just so much mucus or other stuff that's built up inside the alveoli that the alveoli want to start sticking together. You guys know any kind of respiratory disease that might cause a problem with the alveoli not wanting to open? CHF can do it. Yep, because it's fluid. Yep. Yep, and then also COPD. That is why in a lot of those cases we put them on CPAP, because CPAP keeps a continuous back pressure even when they're exhaling, it keeps back pressure in their airways and helps keep those alveoli popped open. And then the other advantage with CPAP, the ones that are closed, there's enough pressure that it will force a lot of those to open up and increase the surface area for that gas exchange. It doesn't open up all of them, but it'll help open up some of them. And it will also help prevent some of them from then closing back up once they're open. But the surfactant is the body's natural lubricant to try to prevent that. So if the surface area is inadequate along the alveoli, or the alveoli are not inflated properly and collapse, that term for that is atelectasis. So, that's just a definition. But atelectasis, if the amount of surface area is inadequate or the alveoli are non-inflated and the alveoli collapse. So if you ever heard him talk about atelectasis, it's an alveoli problem. Okay, so now when we get kind of down into our chest and our lower airway, between the right and left lung is the mediastinum, okay? And that is surrounded by a thick area of connective tissues. What are some of the areas or organs within the mediastinum? Talking about the middle of our chest. Heart. There's a bunch of them. The large blood vessels, the great vessels. So what would those be? Your aorta and the vena cava. Those are the biggest ones there. Okay? And then we still have, even though it's, we're into the chest cavity, they still continue down that far. So we have our trachea and esophagus. Okay, so those are in there as well. And the major bronchi, and then obviously a lot of nerves and other things. Do you know what nerve initiates the diaphragm to work? It's actually on the screen. The phrenic nerve, okay? So the phrenic nerve is the nerve associated with getting the diaphragm to constrict. Okay, we talk about the respiratory system and the cardiac system or cardiovascular system. Often those are, they're two separate lectures because they're two separate things. One is circulating blood, one is getting, circulating air. But these two systems have to work in conjunction with one another. If either one of the systems is not working, it's going to be catastrophic to the health of the person. So even though they're two separate systems, you almost have to think of these as one system. And there are times when this is very, very, very complicated for patients even. Because, I was just having a conversation with a patient the other day who has a very, very rare respiratory disease. And every time he goes to the doctor to try to figure out, he's been dealing with this for years and years and years. He's been to Seattle, I don't know how many times dealing with this, but he goes to his respiratory doctor, and the respiratory doctor always wants to pawn it off on the cardiac doctor because he doesn't really know how to treat it or doesn't know what to do. So he goes to the cardiac doctor, and the cardiac's like, God, no, I can't, this is respiratory. So he has been playing this ping pong game for years and years and years and years and years, even within physicians. But again, these systems have to work together. So really, it would be nice if there was like one type of doctor that dealt with both of these systems, but that's just not how it works. So it can be very complicated in that regard. But the whole point of this, the respiratory system and the cardiac system working together, what's the end goal? Oxygenate, not only the blood, but clear down to the tissues, to the cellular, right? That is the end goal of these two systems working together, to get oxygen to the cells and the tissues, and carbon dioxide and waste products out. So obviously, this is a kind of a no-brainer slide for you guys, but sufficient external ventilation and perfusion are required to deliver the appropriate amount of oxygen to a patient, and it's time sensitive. So obviously, there's certain organs that can live without oxygen longer than other organs. But if you don't have oxygen to the cardiac muscle, you can start seeing irritability in about a minute. No oxygen to the brain, within 4 minutes. Brain damage, it says it's not likely, but 4 to 6 minutes is possible, 6 to 10 minutes likely. So cardiac-wise, how long do you have until you're going to start having problems? A minute. Brain-wise, you've got a little more time. But when you're going to start having brain death or damage, how many minutes? You might start seeing it in 6 to 10, okay? Now, you could have some damage at 4 to 6, but 6 to 10 is where it's like likely you're going to see it. And so, obviously, the longer we keep a patient without oxygen, the worse. Okay, now some of these we're going to get into some medical terminology for the respiratory system and getting air and stuff out of our chest. We typically just call, you'll hear a lot of people refer to all these things as the same thing. They're ventilating, they're breathing, what is their respiratory status. But really, there's some very specific terms for those, and the terminology isn't all the same. Even though a lot of people refer to it to the same thing, the pathophysiology is different. So ventilation is strictly the process of moving air into and out of the lungs. Okay, so this doesn't have to do with circulation. This doesn't get in the oxygen into the cells. Ventilation is just the act of getting air in and out of your lungs. Okay, so that process involves just inhalation. So we need to get the air into the chest. Okay, so what is a major player in the inhalation process? Your diaphragm. That's the biggest muscle that's going to help with inhalation. And again, we still have to have all those body parts of the chest working appropriately. That thoracic cage, the lungs have to be working appropriately, the intercostal muscles and all the chest muscles all have to be working. But the diaphragm is the biggest player. So air, again, enters in through your mouth and your nose, back into your trachea, through the bronchioles, into the bronchioles, into the alveoli, so that it's into your lungs. All right, we covered all of that. Okay, now with ventilation continued, again, we're still getting air into the lungs. This has to do with pressures in your chest cavity. So your diaphragm contracts, and when your diaphragm contracts, what does it do to your chest cavity? Because your diaphragm's pulling which way when it contracts? Is it going up or down? It's going down, so it's enlarging that chest cavity. It's making the chest cavity bigger. What's happening to the pressure within the chest cavity as it gets bigger? Is the pressure getting higher or lower? Okay, the pressure in there is decreasing. So now the pressure inside the chest cavity is lower than the pressure outside of the chest cavity or outside of your body. So when that pressure is lower, what's the outside air want to do? It wants to get sucked in, okay? It's creating that vacuum in the chest by changing those chest pressures. So variations in volume, respiratory rate, or both will affect the minute volume. So what is the minute volume? We talked about this Monday too. It's how much air is getting in and out of the chest in a minute, minus what? That dead air space. But obviously, variations in your tidal volume, which is how much air you're getting in one breath. So if you're taking a deeper breath, obviously, if you do deep breaths for a minute versus shallow breaths for a minute, your minute volume is going to be different, as well as if you're breathing fast or breathing slow, or a lot of those things will affect that minute volume of air getting in and out of your chest. Okay, exhalation. What triggers you to start exhaling? Is it just that all of a sudden your chest cavity is completely full of air and everything's stretched out good? And that's part of it because it happens so fast. But it also has to do with it's a feedback loop in your body from all the different receptors. But the term for that is the hearing Brouwer. I'm sure that's the name of a physician that figured that out, but I don't know for sure. It's the hearing Brouwer reflex loop that prevents overexpansion of the lungs by stopping inspiration. So as your lungs are expanding, there's stretch receptors and other receptors that will trigger a feedback loop to stop you from breathing in. So you don't just keep, breathing, bigger and bigger. Okay, exhalation itself, though, does it require muscles to forcefully blow out the air? Is it active or passive? It's a passive process. Inhalation, active process. Exhalation is not. All the muscles are just returning to their normal state. They're just relaxing, returning to the normal state. It shrinks up the chest cavity back to its normal size and pushes the air out. Now, are there times, though, when it can be an active process? Like asthma is an example of where sometimes it's an active process, because sometimes they'll breathe in and they're struggling to breathe in, but their airways are so constricted that passive process does not work to exhale. And they'll have a prolonged expiratory phase because the air isn't going out. So they will actually be working to forcefully breathe it in and forcefully gut it out because their airways are so small. It's like breathing through that straw. You can't do that passively. It's got to be active both ways. So the body can be active with exhalation as well, but normal conditions when you're healthy and not struggling, it's not an active process. It's just a relaxation. Okay, so maximum expiration occurs when the diaphragm and the intercostal muscles relax, and then that thoracic cage decreases and air is expelled. Okay, so the regulation of ventilation, obviously, there's a lot of the receptors and feedback loops that trigger breaths, that stop the breaths, that decide your respiratory rate. You're going to breathe faster, you're going to breathe slower. There's a whole bunch of stuff that goes into that. The drive to breathe itself is based off of pH changes in the blood and the cerebrospinal fluid. When oxygen levels rise, the respiratory center suspends respiration until rising carbon dioxide levels stimulate the respiratory center. So your oxygen levels are going to rise, but then your body's going to kind of wait for the carbon dioxide levels to rise in conjunction with that and then stimulate the respiratory center to exhale. Okay, so that whole process we talked about, what was the term for that? Getting the air in and out of the lungs? Ventilation. So now we're going to talk about oxygenation. Okay. Oxygenation is a process of loading the oxygen molecules into the hemoglobin molecules in the blood. So now we're down to the cellular level, getting the oxygen out of those alveoli to diffuse across the membrane and diffuse into the capillaries, where they then grab on to the hemoglobin molecules on the red blood cells. And obviously adequate oxygenation is required for internal respiration to take place in order to get the oxygen into those cells. All right. Respiration is yet a different term. Okay. Respiration is a process of exchanging oxygen and carbon dioxide. So oxygenation is loading oxygen molecules onto the hemoglobin, okay? And respiration is exchanging the oxygen and carbon dioxide. Those two are very, 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 very similar. But that's how your book defines the differences of the two. All right. Metabolism. What is metabolism then? When in terms of respirations?
It's the energy output of your cells.
It has to do with energy in the cells, yes. But in this particular case, metabolism is cellular respiration. So now we're basically talking about respiration, which was exchanging oxygen and carbon dioxide, right? Now it's the same thing, but within the cell itself. So the process of the cell eliminating carbon dioxide and getting oxygen on board is cellular metabolism. Okay. Now we talk about metabolism as far as like energy and food production and stuff as well. And I don't know why they kind of use the same term for both of those things. But in this case, when we talk about respiratory metabolism, it's cellular respiration. Okay. External respiration is a process of breathing fresh air into the respiratory system. So with this, we're exchanging oxygen and carbon dioxide between the alveoli and the blood and the pulmonary capillaries. To have adequate ventilation, obviously, moving air in and out of the lungs. Let me rephrase that. If you have adequate ventilation of moving air into and out of the lungs, it does not guarantee that you have external respiration. If you're getting the air in and out of the body, does that guarantee that you're getting the oxygen and carbon dioxide exchange? No. There's a lot of other factors that go into that. Okay, hemoglobin molecules pick up the fresh oxygen, and as it crosses over that, as it diffuses across the membrane. Okay, how many hemoglobin molecules are on a red blood cell? 4. Each blood cell has 4 hemoglobins. So that's the amount of oxygen they can carry. Internal respiration, aren't these terms kind of confusing? I mean, you read over it all. I mean, it's easy when you read in the book, and then you get away from it, you're trying to figure out which was which. It's like, man, they're all so similar. But internal respiration is the exchange of oxygen and carbon dioxide between the systemic circulation system and the cells of the body. So is this happening in the lungs? No. It's the same process, but it's happening somewhere else in the body, whatever tissue it happened to be, where it is then exchanging the oxygen and carbon dioxide at that level of the body. But it's not the lungs that are doing this, it's the circulatory system. All right, we talked a little bit about this last Monday too, but aerobic and anaerobic metabolism. So aerobic differs from anaerobic how? Yep, that is the difference right there. One has oxygen available, one does not. So aerobic, you have oxygen available. The mitochondria of the cells convert glucose to energy, and you get a whole bunch of production of ATP through that Krebs cycle and everything else. Anaerobic metabolism, there is no oxygen available for this one, and it cannot meet the demands of the cells. So the cells, if you're actively working hard and you don't have enough oxygen and you're in anaerobic, it will help you for a while, but it's not going to be a long-term fix. You will not be able to keep up with anaerobic metabolism. You're going to burn out. And this results in less ATP production than aerobic. All right, neuro control. So what are we talking? Neuro control of what? Basically talking about the respiratory system here. So it's all the respiratory centers of this one. So we're talking about how the brain and other neuro pathways affect the respiratory system. So the neuro control originates in the brain and the brain stem, but primarily comes from the medulla and the pons for the respiratory system. The medullary respiratory centers control the rate, depth, rhythm of breathing in a negative feedback loop with the pons. So basically there's a constant communication through that loop, basically letting the body know, do I need to breathe faster? I need to breathe slower? Do I need to breathe deeper? Do I need to breathe shallower? It's just constantly a continuous cycle letting the body know what it needs to do. The apneustic center of the pons is a secondary control center if the medulla fails to regulate appropriately, or if it fails to initiate a respiration, then the apneustic center will then trigger a respiration. Okay, respiratory rate results from interaction between the apneustic and the pneumotaxic centers. Makes a lot of sense, right? Just all these terms. But basically, what you need to know is there are receptors within the respiratory system and the circulatory system that are all talking to each other and letting the body know what it needs to do. So I wouldn't get super caught up in really memorizing some of these real unique terms that you don't see out there all the time. I mean, could they throw one of those on a national registry exam? Yes, I would be shocked, and it would be like one question out of your entire test. I would not focus on that, but just understand the concept that your respiratory system and your cardiac system have to play together, okay? You have to get not only the air into your chest, but you have to get the oxygen through the alveoli to diffuse across the membrane into the capillaries, the carbon dioxide to diffuse back into the alveoli. That also has to occur at all the cellular levels within the tissues, not just the lungs. And all these receptors in your body are going to make sure your body controls the rate and amount of ventilation to control it. All right, so there's chemical receptors as well. Let me see, what do I want to talk about those? Probably not tons. Probably not a bad idea to at least know where these are at, because I would think if they were going to ask a question about this, it would be the where. So in this case, the chemoreceptors are in the carotid bodies and the aortic arch. They measure the amount of carbon dioxide in the arterial blood. The central chemoreceptors are located adjacent to the respiratory centers in the medulla. They monitor pH of the central cerebral spinal fluid. All right, that's good for that. Okay, and then we have the dorsal respiratory group responsible for initiating respiration, and this is based on information it's getting from these chemoreceptors. You getting blurry-eyed yet? I am. Okay. Disruption of pulmonary ventilation, oxygenation, and respiration will cause immediate effects in the body. So if any of those things aren't working, if you're not getting air into your chest, so what would cause you not to get just the air into your chest at all? Could be an obstruction. Could be drowning. Yeah, a crust injury where you can't, the chest muscles aren't working or the airways are just blocked. It could be a severe allergic reaction where the airways are just closing off. Lots of things can prevent air from getting into your chest. Okay, so now let's say those are all okay. You've got the air into your chest. Now what needs to happen at that level? Yeah, you have to get that oxygen carbon dioxide diffused, right? So what could cause issues there? What could be that mismatch that causes issues with that? Okay, there's not enough oxygen even in the air. So you get the air in there, but there's not enough oxygen content. That could be an issue. Or there's too much of something else. Could be fluid. What about a chemical in the air itself that will mess up oxygenation? Carbon monoxide. So now you're getting the volume into your chest, and you're getting oxygen in there, but because there's carbon monoxide present in enough carbon monoxide where it can push off the oxygen, because how does carbon monoxide affect oxygenation? How does it push away the oxygen? Right, it has a stronger affinity to bind to those hemoglobin molecules by a lot. Like, I don't remember the exact number, but it's like thousands times stronger, I think. But so if you have an oxygen molecule and a carbon monoxide molecule, and you have an available hemoglobin, the carbon monoxide is going to win out. The oxygen's not going to get attached. So that's what the problem with carbon monoxide poisoning is it's grabbing onto all those hemoglobins, and the oxygen's not getting to get a hold, so that's not getting circulated. So you're just breathing in the oxygen, and you're breathing it out. You're breathing in, you're breathing out. But it's the carbon monoxide that's taking hold of the hemoglobin. Now, it's never going to be 100%, or if the carbon monoxide levels were so high that it was 100%, they're going to die from that really, 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 really fast. But most cases, you're getting a little bit of both. Some of the oxygen's still attaching to some of the hemoglobins, and a lot of the carbon monoxide is. And so it just depends on those levels how bad it is. But there's another factor that affects carbon monoxide poisoning than just the pure levels. What's the other effect? The length of exposure. So if you don't have super, super high levels, but you're exposed for a long period of time, slowly over time, they'll keep attaching, and you can end up with carbon monoxide poisoning. So in that case, it's still a problem with this ventilatory system, even though it's not truly an airway issue or a volume issue. And there's a little bit of a tangent, but just when you're treating a patient or when you're assessing a patient that you think might have carbon monoxide poisoning, don't just assume that if they're out in the open air that they can't get carbon monoxide poisoning. I try to not tell too many stories, but some of them I think are important. We had a whole family come into the ED when I was working as a nurse in the ED, and they all came in with like flu-like symptoms. So it was the middle of summer, but it just didn't make sense how all of a sudden all the family all at once kind of got sick and didn't feel good, headaches and nausea and vomiting. It's like, well, okay, we're trying to figure it out. Well, in fact, the family had been out on Coeur d'Alene Lake all day boating. It's like, okay, well, what was your boat? Well, it was an open boat. It's just a windshield with an open boat and an outboard motor. Well, would you think that would cause carbon monoxide poisoning? You would think that it would all get blown out, right, and cleared out. Well, they were just putting around the lake all day really, really, really slow. So what they figure is the airflow was kind of going over the boat and then sucking back, how it'll suck back in to the cabin area where everybody was and just getting the fumes off of the outboard motor. And they all ended up with carbon monoxide poisoning. Their levels were high enough that the father and one of the kids actually had to go to Spokane to the hyperbaric chamber, and all the rest just got treated at Cootie. But that was kind of an eye-opener for me because I would have never thought somebody in an open bow boat with just putting around the lake all day would be at risk for carbon monoxide poisoning. But it got I think there was 5 of them, and all of them had it. Okay, the term hypoxia, what is this? It's right here behind me, around the sidewalls. So the tissues are not getting oxygen. So now we're at the tissue level, at the cellular level. The tissues are not getting oxygen. That's hypoxia. So when we talk about our patient being hypoxic, man, yeah, they were super hypoxic. Do we know for a fact that they're hypoxic? Not really. But I mean, really neither do the doctors. They're not, unless they're doing, ABGs. We're just assuming they're hypoxic based off of their signs and symptoms and their respiratory pattern, their oxygen saturations. So we use that term kind of freely, but the true term hypoxia is tissues not getting the oxygen. All right, the hypoxic drive stimulates breathing when arterial oxygen levels fall. This is less sensitive and powerful than the CO2 sensors in the brain. So what condition would you have a hypoxic drive stimulate breathing instead of the CO2 sensors in the brainstem? So these are those COPD pairs, COPD patients that over a long time, their drive, because they have elevated levels of carbon dioxide in their blood all the time, it kind of messes up their drive system, so then they become more dependent on their hypoxic drive, which is oxygen regulated and not carbon dioxide. But even the COPD patients that have that, they've gone to that drive mechanism, it's usually late end-stage COPD. It's not the patient that just has COPD. They're really progressed and they're pretty end-stage by that point. Okay, early signs of hypoxia. So hypoxia again was what? Tissues not getting oxygen. But what do our patients look like when their tissues are not getting oxygen? So what are some of the, they change these into early and late signs. Well, the early signs could be they're restless, they're anxious, they know something's not going, their body senses something's off, they're not getting the oxygen that they need for their demand. They can be irritable, tachycardic. So why is their heart rate going up? Right, so now their tissues are saying, hey, hello, we're not getting oxygen, we need more oxygen. So a way the body can get more oxygen is get more blood cells that have more oxygen attached. So the heart rate's going to pick up to circulate more blood to try to get that tissue more oxygen. All right, late signs, however, get worse. So mental status changes, but now their pulse is becoming weak. Does that necessarily mean it's not fast, though? It can still be tachycardic, but weak. And you'll start seeing cyanosis. Where do you start seeing cyanosis usually first with people? Yeah, lips, kind of sometimes around their eyes. Their face will show discoloration first. Nail beds, But nail beds can kind of, there's a lot of things that can cause discoloration of the nail beds. It could be temperature and other things too, not just oxygenation. So just be careful with that one. But yeah, around the lips and the kind of the face, we're going to see it first. If you have a responsive patient reporting shortness of breath, oftentimes they're not talking in complete sentences. And that's, if they are, but if they're short of breath, how do you want to treat it right away? Sooner rather than later. Give them oxygen. Right away. I'm going to give them oxygen. Now, it's convenient to get a pulse oximeter reading before you put them on oxygen. If it's not going to delay oxygen therapy, I kind of like to have that so we know if we're getting better or worse just based off of that. Even though we know those aren't really that reliable tools, they're still okay for trending. But get them oxygen right away. Now, do we give oxygen to everybody? Like they used to in EMS. Pretty much everybody used to get oxygen. Now we actually do base it off of oxygen saturations for certain cases, but not for respiratory cases. A respiratory patient short of breath gets oxygen. What are the cases that we don't always give them oxygen, even that we may have 10 years ago? Cardiac and neuro. It used to be, man, if they were having chest pain, it was part of the immediate algorithm, man, along with the aspirin and nitro and all that, it was throwing them on oxygen, regardless what their oxygen levels were. It's not the case anymore. And same thing with stroke symptoms and neuro disease. Now we don't give them oxygen as much right away. What does their oxygen level have to be in as far as an O2 sat reading to throw them on oxygen? There's a little bit, depending what the literature you look at, but it's usually like if they're below 92, they definitely need oxygen. There's some variation in the 92 to 94 range. But if they're above 96% or they don't get oxygen. We definitely don't want them to get, if they're 100% oxygenated, just for cardiac and neuro, we do not want to give them oxygen. Do you guys know why? It's vasoconstriction definitely plays a role in it. Yep. And I went to a conference a few years ago with this doctor was from back east. I can't remember his name, but super, super smart guy. This lecture I sat in, he was talking so far over even my head that I got about this much out of it. But basically, what it came up with the studies that they've done, this was specifically talking about neuro cases. When you have a person's body, like their brain specifically, has an area where it's not getting oxygen that it needs. Instantly, it starts opening up secondary pathways to try to get oxygen into the tissue. So it will vasodilate everything it can around that blockage to try to get oxygen to like a stroke patient. Okay, which is great. I mean, that's exactly what the body needs to do. But then we throw oxygen on the patient. When we throw high flow oxygen on a patient that doesn't need it, pretty soon there gets to be more blood in that patient's body. I mean, not more blood, more oxygen in that patient's body than there's hemoglobin attachment points to hold on to that oxygen. So you have every hemoglobin molecule has an oxygen attached, and plus you have a lot of free oxygen there too. And the chemistry here got kind of mind-boggling, but basically the nutshell of it, that makes free radical formation when you have more oxygen than hemoglobin molecules. The bad thing about this free radical formation is it causes vasoconstriction. So now, because of these extra free radicals, because of too much oxygen, the body's own safety mechanism that's trying to prevent this stroke or prevent this blockage in the heart is being disrupted, and it's vasoconstricting. So not only are we not helping by putting them on high flow oxygen, we are truly actually harming them. So that's why now we don't give oxygen to everybody. But in respiratory disease, that's not the case. Because it's not like, maybe that would be an effect if they had a pulmonary embolism in their heart. But if it's just purely like asthma, emphysema, COPD, those kind of issues, too much oxygen is not going to hurt them because it's not going to cause that vasoconstriction, or the vasoconstriction is not the problem. Questions with that?
We got a question on the chat.
That's a good question. So what he's asking is, with the basic curriculum, it's always high flow O2, high flow O2, high flow O2 for everything. I will be honest with you, I have not read your entire chapter with this one. Did it specify? Or is it saying high flow oxygen if they need it? The PowerPoint simply says if they're short of breath, administer oxygen. So I guess basically the answer to that question is I'm not sure. I know all the latest literature, and even from the AHA recommendations now, say for cardiac and neuro, it's not high flow O2, it's based off of oxygen saturations. I don't know if this book says that. I'd have to look into the book more to answer that question. But this book was also just published, so I would be surprised that that's not the case. But I don't have an answer for you until I dig into the book. Okay, then there's this thing called ventilatory perfusion ratio mismatch. Okay, complicated term, not necessarily a super complicated concept, unless you get real deep into the pathophysiology of it. But basically, this is a problem where you have oxygen coming into the lungs, into the alveoli, and you have blood circulating through the capillaries, but there's some condition that is causing the carbon dioxide not to want to diffuse back into the alveoli and the oxygen not to want to diffuse back into the capillaries. Okay, lots of different things cause it. One of the examples I brought up Monday was the CHF, where they had the fluid and there's too much fluid for it to diffuse properly. But regardless what they cause, when you have a problem with the circulatory and the alveoli and they're not working together, even though both independently are working appropriately, but there's a mismatch between the two, that's called a ventilatory perfusion ratio mismatch. And what's it going to cause? It's going to cause hypoxia or lack of oxygen to the tissues because for whatever reason, the oxygen isn't diffusing from the alveoli to the capillaries. And it also can cause an acid-base imbalance because the carbon dioxide isn't offloading, and so now the patient's got more carbon dioxide in their system. Okay, factors affecting ventilation. So we've talked about some of these already. Some of them could be interruptions to the central or peripheral nervous system, which affect breathing. What would be an example of the peripheral nerve, the neurovascular system affecting breathing? How's that? Okay. Yeah. So what would be a damage to the nervous system that would stop breathing? Yeah, broken neck. So yes, caused by trauma to head or spinal cord is kind of the number one thing that comes up where you have a neurological issue that affects breathing. It could be infection. Yep, especially if you had an infection of the brainstem, the spinal cord. Yep, you could definitely have an issue there. All right, hypercapnia. What is that term? Too much carbon dioxide in the blood. Okay. All right, so another factor affecting ventilation, muscular dystrophy. So this causes degeneration of the muscle fibers, slowing motor development, and loss of muscle contractility. So this is a person that has muscular dystrophy is just going to have a lot of issues with the musculature of their lungs and chest cavity, which will affect ventilation. Bronchoconstriction from allergic reactions causes a decrease in pulmonary ventilation due to that whole constriction. So lots and lots of different things that affect ventilation. Some of the extrinsic factors like trauma and foreign bodies in the airway. All right, so hypoventilation. How is this going to affect ventilation overall? So we're hypoventilation. What are we doing? We're breathing too fast or too slow? So we're breathing too slow. Okay. So we're not getting the volume in or the oxygen in that our body needs. What else is not happening? We're not getting the carbon dioxide out because we're breathing too slow. Okay. So typically with hypoventilation, the carbon dioxide production exceeds the ability to eliminate it, and it's usually a carbon dioxide problem before it's an oxygenation problem. So it's usually, if they're hypoventilating, we have a problem of build up carbon dioxide quicker than the body struggles from hypoxia related to the lack of oxygen coming in. All right, and then hyperventilation. In this case, it's also a carbon dioxide problem that's going to be our first initial effect. But what's the problem with the carbon dioxide here when we're hyperventilating? We're breathing it off. We're blowing off too much carbon dioxide. Okay. What are some of the initial effects that the patient has when they're blowing off too much CO2? And it's the anxiety patient that you guys go on that they're breathing 40, 50 times a minute. What do they usually complain of? Tingling. Not only just tingling, but cramping. And it's usually their fingers get all cramped up, and they can't move them, and they're freaking out because it hurts, and they don't know what's wrong with their fingers. Well, it's related to increased carbon dioxide from hyperventilation. And if we can just control their breathing, that'll all self-correct itself and go away. All right, we talked about carbon monoxide molecules attaching to the hemoglobin molecules in a carbon monoxide poisoning. One of this is talking about is how that also can mess up pulse ox readings. So when you have a pulse oximeter, it's viewing the hemoglobin molecules as it passes through in the circulation, and it's looking to see how many hemoglobin molecules have oxygen, but it's not truly oxygen. It's looking like, all right, this hemoglobin molecule is something attached to it. Okay? Can it tell what's attached to the hemoglobin molecule? Can it look and see it's carbon monoxide instead of oxygen? It can't. So you can have a patient with carbon monoxide poisoning, and everything that's circulating, or a lot of what's circulating through their body, is hemoglobin with carbon monoxide attached to it. But your pulse ox reading is going to say 100%. If 100% of the hemoglobin molecules have something attached, it's going to tell you 100%. So in a case where the patient has a risk of being exposed to carbon monoxide, they're presenting like carbon monoxide poisoning, or you just suspect it might be, they're short of breath, not feeling well, and your pulse ox says 100%, what are you going to do to treat them? High flow oxygen, not some oxygen. High flow for carbon monoxide poisoning. And get them to the hospital with high flow oxygen, let them actually do blood analysis and see what levels of carbon monoxide poisoning they have. And they sometimes, if they're not super high where they need a hyperbaric treatment, they will sit there in the ED on a non-rebreather mask for sometimes 5, 6, 7, 8 hours, just breathing high flow oxygen for hours and hours and hours, trying to offset that carbon monoxide. Now, if that's not enough, then they have to get them to hyperbaric chamber to get it dealt with quicker. But yeah, high flow oxygen. Even though your oximeter is going to tell you they're 100%. All right, and then some of the internal factors that affect oxygenation and respiration are just medical conditions, such as pneumonia, pulmonary edema, and COPD. As well as non-functioning alveoli, intrapulmonary shunting, changes in the respiratory rate, pain, emotions, hypoxia, lots and lots of it. There's also metabolism issues, hypoglycemia can affect it, infection can affect it. There's tons and tons and tons of things that affect it. Is it your job to try to figure out what's causing their disruption in their ventilatory or respiratory system when you're on scene? Do you have to know what it is? You don't have to know what it is. And there's a lot of times we don't know what it is. Should you try to figure it out, though, if you can? Right, because it might change your treatment. It might change whether you're thinking, do we need to get the patient on some sort of medication like albuterol to open up the airways, or do they need CPAP? Do they need that pressure to help open up the alveoli? Is it a airway issue, or is it a ventilation issue? Is it a circulatory issue? It just lets you know how you're going to treat it. All right, circulatory compromise also affects oxygen and respiration. And how is that? How does a circulatory compromise affect this?
Since your body demands that oxygen, that's what's carrying it. When you have basically an interruption, your respirations are going to increase to try to supply more oxygen to your system.
Right, and the key there was the circulatory system carrying the the red blood cells carrying the hemoglobin. Okay, that's all the cardiovascular system is carrying that. Those red blood cells and the hemoglobin. Okay, if you have an issue with the cardiovascular system, such as you have an MI going on where the heart muscle is affected, or the hypovolemia where their blood pressure is down, or whatever's causing the circulatory system not to get that blood circulating as well as it should, you're going to decrease the amount of oxygen it could take on, or the amount of carbon dioxide it can offload. So that's why your circulatory system plays a vital role in oxygenation and respirations. All right, so some of the specific things here it talks about is a pulmonary embolism. So it's an emboli. So what are some other examples of problems where you have a problem with a blood clot? That's not a pulmonary embolism. So a stroke, you have a problem with a blood clot affecting an artery in your brain. Okay, what about a heart attack? It's not always a blood clot. It could be plaque or something else, but you have an artery in the cardiac muscle that's blocked. Pulmonary emboli is the same thing. It's just in the vasculature of your lung. So basically a stroke and a heart attack and a PE, pathophysiology are very, 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 very similar. They're arteries that are obstructed, okay? But the lung, if it gets into the lung, it comes from it's called a PE. Where does that typically come from if it's going to get into the lung? Where does the blood clot originate? Almost always comes from the lower extremities. Because if you think about it, the vascular system, when it's returning to the heart, it's getting bigger and bigger and bigger and bigger as it goes back to the heart, right? The blood vessels aren't getting smaller and smaller and smaller like they are if it's coming away from the heart. So you get a blood clot, there's nothing that's going to stop it all the way up until it gets into the heart, circulates through the heart, and then it gets into the lungs. Now when it's in the lungs, the blood vessels are starting to get smaller and smaller and smaller and smaller because they got to get down to that capillary level for that oxygen carbon dioxide exchange. So that's why the clot can come from a lower extremity and not stop until it gets into the lungs, because the blood vessels are big enough it can handle it until you get into the lungs. Now, it depends how big a clot you have and how much of the lung it knocks out or where it is in that area, whether it's super bad or not bad. People have small PEs all the time. They might not even know. They don't even feel. A large PE can kill you on the spot. So there's a lot of variations in pulmonary emboli, just like there's a lot of variations in severity of strokes and heart attacks. All right, what is a simple or tension pneumothorax? How is that affecting oxygenation and respiration? So first of all, what's happening in there? Okay, it's actually an issue of we talked at the first class how there's that surfactant around the lungs, and then there's that cavity within there's a barrier, or a space is probably a better term. I'm trying to think how to do this. A space between the lung itself and the lining of the lung, and there's that surfactant in there. So if you start to get a bunch of air in there, okay, that's a pneumothorax. And what will happen to the lung tissue itself, it just starts to get pushed smaller and smaller and smaller because there's air built up around the outside of the sac. Now, that would be basically a simple pneumothorax. A tension pneumothorax is where you get so much pressure that the lung is completely collapsing down and not working. And also, it'll start getting so much pressure, it'll actually expand the lining of the lung as well. And it'll all start pushing on the heart. And when the pressure within that system also starts affecting cardiac output, that's a true tension pneumothorax. So if you don't have hypotension associated with your pneumothorax, it's not a tension pneumo. So a tension pneumo is hypotension caused from cardiac output obstruction related to the tension pneumothorax in the lung. All right, an open pneumothorax, it's the same thing. It just has an open area from the outside of the body in. Most pneumothoraxes are open because most of them are caused from trauma. And most of them would be like a stabbing wound. That's where most pneumothoraxes come from, but they don't have to. And they don't even have to come from trauma. You can get a spontaneous pneumo where something in your lining in your lungs just gives out. And it could be caused from a cough, or it could just be caused from an infection or something else. You can just end up with a pneumothorax as well. But most often it's trauma, and most often it's penetrating trauma. All right, hemothorax, what's different in that? What is that term referring to? The same concept, but instead of air, it's blood. And frequently, if we're talking about penetrating trauma, what do you think they normally have? It's the next term, hemopneumothorax, which is both blood and air, causing the same exact issue. All right, so if you have that patient with a hemothorax or a pneumothorax, what is your treatment for him? Oxygen and transport, right? It's not something you're going to treat in the field. Now, if it's a tension pneumo and you had a medic there, they could dart the chest. But we don't only do that if they're hypotensive. So a simple pneumo, it can actually be a fairly severe pneumothorax. But if it's not a tension pneumo, we're not going to treat it other than oxygen and transport. Get him to the doctor who can take a look at it, do a chest x-ray, and decide what they're going to do. Often they'll just stick in a chest tube in the ED. Have any of you guys ever got to witness a chest tube being put in the ED? I hope I never have to have a chest tube put in the ED. It looks awful. It's like taking a garden hose. And they'll numb it up a little bit with lidocaine, but I don't think it does a thing. They cut a big hole in the chest. The doctor typically sticks his finger in the chest and makes the hole bigger. And then they shove this garden hose into their chest. It looks awful. And the patients are not put asleep for it. They're awake. All right. Now, heart failure and cardiac tamponade also can affect oxygenation and respiration. So heart failure itself, we kind of talked about that already. The heart is just not functioning so as well. It's not going to have the cardiac output it needs. Blood pressure is going to be low. Circulatory output isn't going to be as much. It's not circulating the volume it needs. And so obviously you won't have the oxygenation and respiration happening there. What about cardiac tamponade? What is this? It's somewhat similar to a pneumothorax in pathophysiology, except instead of it being the lung, it's the heart. So again, that heart has that pericardial lining. It's a hard, fibrous lining. The problem with the lining of the heart, which is a little bit different than the lung, it doesn't want to stretch. Okay, that lining is pretty much fixed where it is. It'll stretch a little bit, but not very much. So now if you start getting air or blood or something in that lining, and it's building that pressure in there, instead of that lining getting bigger, it just starts pushing the heart smaller, pushing on the heart, pushing on the heart. Pretty soon it'll be enough pressure where your heart just cannot pump because there's too much pressure. It can contract, but it just can't open up the chambers of the heart anymore because of that external pressure. So that's cardiac tamponade. The treatment for that for us, all of us, paramedics included, is just rapid transport to the hospital so they could go in there and relieve the pressure of the sac around the heart. All right. We used to. No, Idaho took that away from us.
Oh, really?
Yeah, that's no longer in our scope of practice. So they took that out, 5-6 years ago, I think. But yeah, we didn't do very many of them. I only got to do a couple of them on dead people anyway. It was when I first started working as a medic. I was talking to the ER docs because I wasn't really quite clear. Okay, if I go into a traumatic arrest, how much work do you guys want us to do in a traumatic arrest before we called it? And the doctor I talked to was like, well, basically, the only thing that's going to save them from a traumatic arrest, especially if you're not at the hospital already, is either tension pneumothorax or cardiac tamponade. If it's not one of those two things that you can fix right now, they're pretty much done. So he's like, do bilateral, dart their chest and do a pericardial centesis, and if that doesn't fix it, you're done. So I got to do a few of those before they took it away, but that was it. It never helped them. Yeah.
As far as signs and symptoms, did you expect increased respirations, narrowing blood pressure?
For the tamponade? Yeah. And they say that the classic sign is really what you're listening to, besides just the decrease in cardiac output, is muffled heart tones. But the problem with that is, if you really want to listen for muffled heart tones, what do you have to listen to all the time to know? Normal heart tones. How many of us listen to heart tones? Yeah, right. So unless you're listening to heart tones all the time and you really know what a good heart tone sounds like, you're probably, unless it's really, really, really obvious, you're not going to know muffled heart tones. But that's but between the cardiac output issues, that's the other sign that you're looking for is muffled heart tones.
So then aside from just trauma, is there any specific infections or?
It's the same thing. There's a lot of things that can cause it, but it's really rare. It's even really rare in trauma.
Right.
You don't see cardiac tamponade much at all. All right. Hemorrhagic shock can also affect, obviously, oxygenation and respiration. So this is just we're bleeding out. So we're bleeding out. We're losing our volume. Vasodilatory shock. So what is an example of this? So it's a vascular problem. It's a shock causing the blood vessels to expand, decreasing our blood pressure. So what are some examples of the shocks that cause that? Okay, septic shock causes diffuse vasodilation. So if you have a patient in septic shock, that is a problem there. It's a vasodilation issue. Same thing with neurogenic shock. So a spinal cord injury that results in shock is because the blood vessels lose that impulse to stay contracted, and they're like, oh, cool, we don't have the impulse to stay contracted. It's vacation time, so they all relax. Blood pressure dumps. And then anaphylactic shock. Anaphylactic is kind of a double whammy because it affects cardiac and respiratory. So cardiovascular anaphylaxis causes vasodilation. But what does it do to the airways? It's going to cause bronchial constriction. So it's a double whammy when we're talking about oxygenation and respiration. Anybody in shock, of any of these type of shocks, we need to treat them rapidly to try to prevent the shock from getting worse, whether it's, IV fluids if they're, hypovolemic, or if it's just oxygenation, high flow O2, or rapid transport, or whatever it is. Once they get to those levels of shocks, it's rapid treatment until we can get it turned around. Okay, break time. Take 10. Because you're going to get out early today anyway. Any other questions for you guys off-site? All right, ready to get going again, guys? Okay, I've had a couple of questions. I was actually going to talk about this at the beginning of class, but I forgot, but it was brought up again during break. If you're off-site or if you view a recording of the class, and please either text me or email me that you watched it, just so I can get you added to the roster. Now, I am anticipating all of you guys passing this class with no problems, and in that case, it doesn't really make any difference because there isn't an attendance requirement necessarily for this class. But where it will affect is if any of you guys don't make it through the test and get licensed at this next level, then you can go back and use all these hours for CE hours. So then I'll need to have rosters showing that you guys were actually here or viewed the class for your CE hours. I'm crossing my fingers that none of you are going to need that. You're all going to pass the test with no problem. And then your CE hours start over anyway at the next license level. But just in case, so you don't end up having to go back and try to figure out, okay, well, which ones did I make, which ones did I didn't make. If you weren't here in class, if you're here in class, I'll get your roster. But if you watch it after the fact or view it later, let me know. Even if you're off-site, though, and you view it live, we're still keeping track of people that are logged in off-site on the live roster. So in that case, you don't need to let me know, as long as we have record of you being off-site. But it's just if you view it after the fact, the recorded version, please let me know that you watched it. I am going to pass the roster around for those of you guys that are in the classroom. I'll just have you mark that you're here. So, Matt, if you don't mind throwing that around. Those of you guys that are logged online, as long as there's only one person right now off-site, I can see who's logged in. If there's anybody watching it with you, like if you're at a station with someone else, please put their name down in the little chat area or something so I know to mark that they were here too.
There was one in the back too. I think a lot of people signed.
Oh, okay. Then don't worry about that one. That's probably even a different date then. So, okay, cool. All right, so now we're going to change gears a little bit. Now we're going to get away from the anatomy and a little bit of pathophysiology, which is, and I'm sure, a welcome thing for all of you, as some of those terms and understanding all that stuff can be kind of mind-boggling sometimes. So now we're going to get more into actually assessing a patient and treating a patient with respiratory or ventilatory issues. So we're going to start out by just doing a patient assessment of the airway. So when we assess the airway, initially, are you actually looking at the airway itself, or what are you really looking at? You're really looking at their ability to breathe. Because if they're breathing, what is their airway? It's open, right? Now, could there be issues where it's somewhat compromised? I mean, could you be breathing and have stridor, and you can hear a stridor sound? Well, that's going to be an upper airway problem, okay? But if they're breathing, at least it's open to the point that they can actually breathe, okay? So initially, we're just looking at breathing. So that begins by looking at their respirations or their respiratory system. So we'll start by looking at or evaluating respirations. But again, we talked about this before. Remember, people have a funny thing when they know you're counting respirations, they change their breathing pattern. Now that is only for a normal person that's breathing normally. If you're in respiratory distress, are you going to change your breathing pattern because somebody's counting your breathing? No. So really, if you're evaluating somebody's breathing and they change it because they know you're watching them, well, obviously they're not in any kind of respiratory compromise to begin with. So it's not as critical. But evaluate their breathing. Now, oftentimes we get lazy in EMS. I mean, I do this as well, and all of us are guilty of it, where we look at someone's breathing and we estimate their respiratory rate. Okay? Try not to get in that habit. Really try to work on counting their respiratory rate. Because there are sometimes where we're wrong, from, you know. And I mean, there's been sometimes where I'll look at a patient, it's like, okay, yeah, they're breathing at 30 times a minute. And then when I get a second where I can actually physically count it out, it's like, oh no, they're breathing at 45 times a minute. Now, are we going to have a drastic change in how we treat that patient? Probably not. But is there a big difference when they look at that clinically from the physician standpoint or the pulmonologist that's maybe looking at a report later, 30 versus 45? That's a pretty significant difference in your respiratory rate. So try to get as accurate count as we possibly can for evaluating respirations. So what is the normal range for an adult? 12 to 20. As you get younger, does that get higher or lower in rate? Higher. The younger you are, the quicker it gets. Okay. And then we're also going to look at depth. So we're kind of evaluating that tidal volume. So how are they breathing? Now, if, like all of you guys in this room, I can hardly see you breathe because you're not taking big, huge breaths. Okay. So is it normal if you can't see a huge, big tidal volume breath? That is normal, right? Because they're not struggling to breathe. You're not working hard. Your body doesn't need tons of oxygen as you sit here in the classroom listening to me. And actually, you know, it's listening to me, it practically puts you to sleep. And so your whole metabolism, everything is dropping down to nothing. But yeah, you don't need a lot. So you're not breathing very deep. If you have a patient in respiratory distress or having respiratory compromise or a cardiac issue that's changing their ability to circulate that oxygen and offload the carbon dioxide, their respirations are going to get bigger and deeper. Okay, so then you're looking more at that. Okay, look at the pattern of their breathing. Normally, a breathing pattern should be a normal, regular pattern. Even people that are struggling to breathe typically at a regular pattern. Okay, if they're breathing in a weird, irregular, fast and then slow and fast or slow or some odd pattern, that's a sign that something else is going on. And just be aware of that. There's different conditions that we'll talk about that include those. I don't remember if we'll cover all those today, but later on we'll talk about some of the conditions where you'll see changes in respiratory patterns. And then lung sounds. Say again, lung sounds should be clear. Now, again, not absent, but clear, where you're not hearing any avitation sound. You're just hearing that airflow in and out, in and out, in and out. But you want to hear airflow in all lung fields. And make sure I'm on the same straight. Yeah, okay. Okay, so respiratory distress can be caused from lots and lots of different things. But when we're talking about airway, so airway obstruction can cause respiratory distress. What are some of the things that can disrupt the airway or obstruct it to cause this distress? Choking on what? What's the number one thing that causes airway obstruction? Yep, choking on your own tongue. Okay? That's the number one cause of respiratory obstruction. What patient population can have a problem where their own tongue is causing the airway obstruction? It's usually patients with some sort of issue where they're having an altered level of consciousness. Okay? So either severe trauma where they've been, they got their head run, their head injury where they're out enough where they're no longer controlling their tongue and it's falling down in front of their airway and they can't control it. Or it could be where I've seen it probably the most frequent is severe alcoholism. So you go on those really bad alcoholics that snoring respirations, their tongue is falling down in front of their airway. You stimulate them, wake them up, their airway clears. The minute you let them go, everything's kind of obstructed again. Now, they're not usually totally obstructing, but partially obstructing in that case. If they totally obstruct, that might be your alcoholic that drank so much that they completely obstruct and they die laying there, and they get found later dead, unless there happened to be a family or friend with them at the time. But yeah, so it could be any kind of foreign body. It could be another cause of airway obstruction. Again, we talked about earlier. It could be that epiglottitis. It could be just a severe, like an allergic reaction where their airways are just constricting so small that they're not getting the airway or the adequate volume through it. Okay, inadequate ventilation. So what could cause you just not to ventilate as well? We talked earlier about like crush injuries. Then another term that came up during the lecture this morning was that muscular dystrophy. We are having a problem with the actual chest muscles themselves and the thoracic cage and stuff affecting their ability to breathe. But there's a lot of different issues or medical conditions that can cause that. All right, impairment of the respiratory muscles. Again, we've talked about that. Impairment of the nervous system. We've talked about the spinal cord injury and other issues causing respiratory problem. Okay, so then it has this term dyspnea. What is dyspnea? What does that medical term mean? Basically, it's a medical term for difficulty in respiratory rate, regularity, or effort. Basically, they're short of breath. So they have some sort of issue causing them to be short of breath. The clinical word for that is dyspnea. Now, that can result in hypoxia. But again, what? Or hypoxemia. What is hypoxemia? So the word emia refers to what? Blood. So now we're getting low oxygen levels in the blood, which will result in hypoxia, which is low oxygen levels where? In the tissues. And if it's untreated and it doesn't improve on its own, it'll result in anoxia and death of those particular body cells or tissues. All right, so we're still talking about recognizing inadequate breathing. So determine when assessing the patients with respiratory distress, you want to see how they're positioning. So first of all, is the patient positioning themselves in a way to help improve their own ability to breathe better? So what does that patient typically look like that is truly struggling to breathe? How do they typically position? Okay, the tripod position. So what is that? You're leaning forward, usually kind of on their elbows, sometimes on their hands, but they're leaning forward, bending forward, holding up their chest. But they're not the guy that's sitting back in the recliner just hanging out, right? They're forward and they're actively breathing. Just that positioning helps. It'll help get fluid kind of lower in their chest if it's a fluid problem. It helps their ability to the thoracic cage to just open up better and the musculature to work better. There's less weight of the patient's own body weight laying on the chest if they're in that position, because more of that just goes down to the dependent area. So yeah, that tripod position. Okay, is the patient experiencing orthopnea? What is that? So when we talk ortho, what is that? Positioning. So are they positionally short of breath? So that would be a patient, you sit them in a chair, and they're sitting upright, they're not short of breath at all. Or they might feel short of breath, but they're not actively, like, really struggling to breathe. You lay them down, and now they can't breathe at all. They're struggling, and they're getting anxious and panicking because they can't breathe. What type of patient might experience that? Could be COPD, but it's usually obesity can cause it, and severe congestive heart failure can cause it. Severe fluid, because what will happen is they're sitting up and the fluid goes dependent in their lungs, right? It's gravity's going to help it pull down. They lay down, and where's all that fluid go? It diffuses through more of the lungs, and it makes it hard. Now they feel like they're literally drowning and can't breathe. You sit them back up, the fluid goes back dependent, and then they have an easier time breathing again. That's not going to fix them, but we want to position them in a way that they're the most comfortable while we get other treatments going. All right, is there adequate chest rise and fall? So again, just are they getting the tidal breaths that they need for their current respiratory status? Are they gasping for air? And one thing to, a common way that they'll describe this, like when you talk to the nurses and doctors at the hospital, is how many word sentences are they able to do? Do you guys know what that even means? Say, it's basically how many words can they speak in a row before they have to take a breath. And if you're only able to speak 1 to 2 words, and then you have to take a breath, you speak another 1 or 2 words, and you have to take a breath. That's severe respiratory distress. Okay? The more, if you're up in the 5, 6, 7, 8 words a minute, a breath, that's better. So oftentimes you'll see that's how they'll describe a patient. Patient only able to speak in 1 to 2 word sentences, or 3 to 4 word sentences. It's just an easy way to let somebody else know how short of breath they really were when they're not just talking about respiratory rate by itself. All right, and then what goes along with their respiratory status is the cardiovascular status, but how do we see the cardiovascular status? Through the skin color, right? It's our external view into the cardiac. So what is their skin color? Is it pink? Is it pale? Is it cyanotic? Is it dusky? Look at the skin color to give you an idea of how well that oxygenation is occurring, that onboarding of the oxygen and offboarding of the carbon dioxide. All right, is there flaring of the nares? So nasal flaring. The nose, the actual opening of the noses get bigger. Now, what population do you typically see this in more often? Children. You can see it sometimes in adults, but it's much more prominent in children, that nasal flaring. If you have a kid that you notice nasal flaring, that's a big deal, okay? Because they're already doing what they can to compensate for their shortness of breath. But what is the difference between kids and adults when we talk about compensation? Yep, they compensate really, really well. Way better than adults. So you don't see as many signs and symptoms. But then when they quit compensating, it's a cliff, man. They fall off the cliff. Where adults don't compensate as well, it's more of a gradual thing, and then it's a more gradual down. Kids will catch you, kids will throw you, because you'll look at them, there's very subtle signs that you might see that they're not doing well. And if you don't pick up on those, you might think the kid's doing fine, and then all of a sudden they're crashed. So just be careful. All right, pursed lip breathing. What is this? Okay, so why would they do that? Why would they be breathing out of pursed lips to try to increase that pressure? Yeah, they're basically, they're giving themselves PEEP, or like CPAP, right? They're producing PEEP, that positive pressure through their expiration to try to help keep their airways open. That's a body's just natural way to try to do that all by itself. All right, using accessory muscles to breathe. So these are the muscles where? Okay, it's your intercostals and some other muscles in your chest. So it's not just your diaphragm working. All those. Now, do those muscles work all the time? They do during even normal breathing. But now they're really working. So if you take off their chest and you can see, all those muscles just really contracting with every breath. And they're using their intercostal muscles. And it's a sign of shortness of breath or dyspnea. Again, that's mostly going to be seen in children, or it's going to be more easily seen in children than adults. All right, is the chest wall moving symmetrically? So basically, I want to see both sides of the chest, and I want it to look the same. You don't want any kind of seesaw respirations, or you don't want one side of the chest really expanding and the other one's not moving very much. You want it to be equal. If you have a patient where one side of the chest is like expanding more than the other, what do you want to know right away if you haven't done so already? Lung sounds, right? But you also need to ask the patient if that's normal for them. Some people have issues that's a normal thing for them. Different people with different neurological problems or musculature problems might have like a side of their chest that's paralyzed per se. You can actually get all that side of your chest, the nerves not to work, and your chest is basically paralyzed and the muscles and stuff don't work normally. Now, your lung's still there. That part's still okay. But when you breathe, you don't have equal chest rise and fall because of that. You don't see a lot of those, but I've seen a handful of those over the years where one side or the other side is affected due to some medical condition, and that chest just no longer acts normal. So find out if that's a normal thing for them. Okay, and then is a patient taking a series of quick breaths followed by prolonged expiration phases? So I'm breathing quick, then I'm breathing out long. I'm taking these long expirations. Why am I breathing out a long time, exhaling? What am I trying to do? I'm trying to breathe off CO2, right? So for whatever reason, they're acidotic and they're trying to correct the acidosis by trying to get rid of more of the CO2. Now, is CO2 truly an acid? It's not. It affects the acid-base balance, but you can't think of it as like, oh, they're blowing out their acid, because it's not. We kind of describe it that way to make it simple, but it does affect the acid-base balance by blowing off excess CO2. Okay. Obviously, if a patient has inadequate breathing, they may be appearing to work hard to breathe. Okay, that's pretty obvious. But does everybody that has shortness of breath look like they're really, 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 really working to breathe? What patient might have a severe respiratory disease or problem, but they're not working very hard? And basically what I'm describing here is somebody they're on the downward slope. Okay, they've been in severe respiratory distress for whatever the condition is, and they're working, and they're working, and they're working, and they're working, and then all of a sudden they're not working as much. Is that like, oh yeah, man, we're doing good, they're getting better? What should you also think? They're wearing out. Okay? They're physically cannot keep their respiratory system up with the demand. For whatever mechanism in their body isn't working is not getting better, and they are getting exhausted and can't keep up. So obviously you have this patient in severe respiratory distress. We're trying to treat them, and then all of a sudden their respiratory rate drops. They're not breathing as deeply. They're chilling out. What do you need to get ready to do? Get ready to start ventilating, breathing for them, because they're going to stop. If we can't get that situation turned around right now, they're going to stop. And they will just get so fatigued they can no longer breathe anymore. And you'll see that patient every now and then that they look like they're getting exhausted. And it is perfectly okay, even if they're conscious and awake, to ask them if you would like us to help breathe for them. That doesn't mean we have to throw an airway in them. Doesn't mean we have to put them under. But oftentimes they will feel better if they're to that point, just with us assisting their breathing with the vague valve mask. So please don't forget that that is an option to help these folks that are just wearing out. All right, so we talked about the normal respiratory rate being between 12 and 20. So by the book, if you're lower than 12 or above 20, it's a sign and symptom of some sort of respiratory compromise. Does that mean everybody that doesn't fall within those numbers is having respiratory problems? No. There's frequently that you'll see patients breathing, 8 times a minute, 10 times a minute, or 16 or 20 times a minute, and they do not have any issues whatsoever. That might just be their normal respiratory rate. But just know if you're out of those normals, just think or start deciding for yourself, okay, is there a respiratory or ventilation component with this or not? And you need to explore it. Doesn't mean you have to treat it. It doesn't mean that there's a problem, but you should probably at least, if they're not within their normal range, explore whether they are truly having issues or not. We already talked about an irregular rhythm of breathing. I don't know why we kind of talked about that twice. Diminished, absent, or noisy auscultated breath sounds. So any abnormal sound when they're breathing, or in their chest when they're breathing, is a sign that there's a problem. Now, there's lots of different sounds that mean different things, but at this point, all you need to know is if it's noisy for any particular reason, that's bad. Okay, reduced flow of expired air. So what does that mean? They're just not able to breathe out normally. Why would you not be able to breathe out normally? Yeah, so asthma would be a primary example of that, because again, breathing out is typically a passive process. It can be an active process if it has to be, but it doesn't function as well as inspiration because the muscles and stuff aren't set up to breathe out as well. So severe bronchospasm has a harder time getting the air out. So they're trying to force it out, but the mechanism does not work as well. So there's that prolonged expiratory phase where they have to try to blow it out longer, and it's going to be diminished because it's just not the airflow going out. We already talked about chest expansion. Talked about most of this already. I'm going to jump kind of down to the bottom of the slide. Evaluate for pulsus paradoxus. What the heck is that? Are you evaluating the respiratory system in this or the cardiac system? Kind of both, but it's really cardiac. It's blood pressure. So it's a drop in the systolic blood pressure of 10 millimeters of mercury or more during inspiration. Okay, that's what that is. Other than knowing that for a test question, and if you happen to have one on the NREMT, I don't know if you guys have one for me because, again, I don't read all of our test questions. I just randomly pick them. In the real world, that means nothing to us. I've never evaluated a patient for pulsus paradoxus and have that change my treatment. But that's what the term means. So that's what it is. They say you see it in cardiac tamponade and asthma, according to your guys' book. Cardiac tamponade and asthma. Okay, so now we do have protective reflexes of the airway that aren't, well, I'm not talking like the epiglottis, which is protecting the airway. There's just ways the airway can try to protect itself from different things. And a couple examples of this would be a sighing. Now, why do you sigh? I mean, basically, what is a sigh? It's just truly a big, deep breath, okay, typically. Yawn's kind of the same thing. But what is the functionality in the body? What's it really doing? It's getting more oxygen, but it usually has nothing to do with oxygen. It actually is to try to pop open your alveoli. Because if you're not breathing for a long time or not taking deep breaths for a while, which happens when you're sitting here, what'll start happening with your alveoli? They'll start closing off because you're not taking deep breaths, and they'll start closing off. So every now and then your body's like, okay, enough of this. We need to pop these suckers back open. So you'll take a big sigh or a deep breath, and it'll pop all of those back open. And usually you don't even realize you've done it. Every few minutes you sit, all of a sudden you'll take a deeper breath, and you guys don't even know. But that's what's happening. Your body is popping open all those alveoli back up to try to make sure that they don't start adhering and sticking to each other. And then hiccuping is mentioned in this as well. I have absolutely no idea what the purpose of a hiccup is in your body or why your body does it. No idea. Yeah, noisy, right? All right. Serious head injuries. So again, this could cause inadequate breathing, but what would a serious head injury cause? What effect would it have with your respiratory system? More often, it's just decreased respirations in general. Due to a lack of either you won't be breathing at all if you have a severe spinal cord injury, or it just, for some reason, it just knocks out your kind of the CNS drive a little bit. Your respiratory rate drops and your tidal volume gets less because you're not taking big, deep breaths. And if you have a respiratory pattern that's irregular with ineffective respirations, the term for that is ataxic respirations. Okay, agonal gasps. What are these? Okay. Is it truly a breath? No. It's more of a muscular reflex of your body at the end of life or right before the end of life where the musculature is kind of working, they're trying to breathe, but they're not really getting air in and out of their chest. They're not getting the oxygen exchange. And this can actually happen for a long time after death. One of the things that annoyed me to death sometimes on a super busy day in the ED was a patient with agonal respirations because we could not send a patient to the funeral home until they quit these, and they would have died sometimes 30, 40 minutes, an hour ago. The longest I remember was about an hour and a half, where they'd have these stinking agonal respirations. We're trying, not to be insensitive, but they're already passed away. We're trying to get this room cleared out so we can see other patients, but this person's just in there taking a breath every minute or so. I can't get rid of them until they quit breathing. So, but yeah, if you see somebody with agonal respirations, it's not truly a breath. Their body's kind of trying to breathe. Their musculature is trying to breathe. They look like they're breathing, but they're not exchanging airflow. So if they have a pulse in agonal respirations, what do we need to do right away? Ventilate them, because pretty soon they're not going to have a pulse, right? And you're not going to see that very often, because you're basically going to have that patient go into agonal respirations right in front of you or right before you got there. Because if that didn't happen, by the time you get there, they're going to be in cardiac arrest. Now, every now and then we will have our patients that are in cardiac arrest, though, that we're treating that still have these agonal respirations, because again, they can go on a long time after they die. So if you're at a scene of a cardiac arrest and the patient looks like they're trying to breathe, it's an agonal respiration, just basically disregard it and treat it like they're not breathing at all. Just do your full BLS treatments. Okay, so we already talked about skin color, how the circulatory system is, the skin is our eyes to the circulatory system and how it interacts with the respiratory system. So think about that, think about level of consciousness. Again, always consider the possibility of anybody that has an altered LOC. If they have an altered LOC, consider that it might be respiratory in nature. Now, there's a lot of things that can cause problems with LOC, but don't discount that it's oxygenation or airway, okay? So with that being said, how are you going to know if you have a patient with altered LOC if it has anything to do with airway or ventilation or oxygenation? So first, make sure they have an open airway, right? If they have an open airway, is that the cause of their altered LOC? No. Okay. Now, we're going to assess their lung sounds. So they have good lung sounds. Okay. Great. Are they breathing adequately? If so, great. Get a pulse ox reading. Is it in a normal range? Great. If in their skin color, look at their skin color. Is their skin color normal? If all of those things look normal and they're altered, do you think it's caused from respiratory ventilation? No, probably not. If you find a problem with any of those, then we need to treat it and see if that fixes it or makes them better. May or may not. Depends what the cause is. Okay, it says determine a baseline mental status and consider proper oxygenation when assessing patients. So everybody, when we do an assessment, we're going to assess baseline LOC, respiratory or not. Okay, pulse oximetry. Again, this is measuring what? How many molecules are attached, or how many hemoglobin molecules have things attached to them, right? So that's all it's looking for. Can't guarantee it's oxygen, but that's what it's looking for. So that light is shining down there, looking at those red blood cells, specifically looking at the hemoglobin molecules. There's lots of different things that could cause it to not work properly. What are some things that might make your reading not work? We already talked about carbon monoxide, but what about just the ability for it to read at all? What might give you some weird readings? Cold extremities. So if they're cold, what's happening to the capillaries in their fingers? They're shutting down, right? It's shunting the warm blood to the core to try to keep the core warm. And so now we're not getting much circulation through our fingers. That's why it doesn't work as well in cold, because there's not the circulation through it. Now, obviously, anything that obstructs the little ability for the light to penetrate through and look at the nail beds, is going to affect it. Like sometimes fake nails affect it. It can read through some of them, but sometimes it doesn't. If they're moving a lot, moving their fingers a lot, obviously it'll affect it because it'll read and then it won't read and it'll read and it won't read. But I think pulse oximetry is a great tool, but just don't 100% rely on pulse oximetry. Make sure you're also looking at all the other signs and symptoms and tools and other things. Don't just rely on that. And I think as a general rule, and again, I'm guilty of this as anybody else, when we assess a patient's heart rate, we get really lazy that we put the pulse oximeter on their finger, and now that is their heart rate and their respiratory rate and their pulse ox. Is that really their heart rate? Maybe. Maybe not. Do we still need to check a pulse or have them on a monitor, which is also reliable for identifying a heart rate? One or the other. But just relying on a pulse oximeter to get all your vital signs is probably not the best plan. Sometimes pulse oximeters are mind-boggling to me. I can't tell you how many patients when I worked in the ED, I'd go in and look at the monitor, and it'd have a pulse oximetry reading, and I'd look at the stupid finger probe, and it's lying in the bed next to the patient, not even on them. How it's getting a reading was beyond me, but I saw that happen a lot. So they can be, you can get erroneous readings from them. So what is a good indication, if you have the ability to monitor this, that the pulse ox reading is more accurate? If it has a pleth wave, okay? Now, not all pulse oxes have it, but the ones that are attached to our Zone monitors do. So if you look at the wave that's associated with your pulse ox, and it's a nice wave pattern, you're more likely to have an accurate reading with that. If the wave pattern's all over the place and not accurate, not a nice normal just up and down pattern, then your reading is inaccurate. And another thing to look for is look to see if the heart rate that the pulse ox is giving you matches the heart rate that the cardiac monitor is giving you. If the heart rates vary, then it's not an accurate reading either. Okay, peak expiratory flow measurements. So this is something that a pulmonologist will do, or some doctors will do. If you have asthma or some respiratory disease, they will get these measurements. Okay, so this is where you're actually taking and you're breathing like as hard as you can into these tubes, and they're measuring the amount of air you're exhaling. It helps evaluate the amount of bronchoconstriction, like for an asthmatic patient. The values aren't always the same for everybody. They differ based off of age. They differ off of male or female, height, weight. So different things affect those readings. So there's not like one number that this is good for everybody, like some vital signs. We don't really do these, but that's just what it is. It's to evaluate for bronchoconstriction. When they do the test, they'll actually do it 3 different times, and then they take the best reading of the 3, and that's what they count for the value. Not really quite sure why they think that's important for you guys to know, but. All right, arterial blood gases. Again, I'm not going to cover this very much because it's something we don't do in EMS. We don't read arterial blood gases. But when you talk about the hospital setting, this is the gold standard for evaluating respiratory patients, okay, is an ABG. Now, there's a couple different ways that they can do this. They can just do a blood analysis where they take a blood sample, they take it and run it through a machine to get the ABG values. But if they have an arterial line, like a patient coming out of, a lot of the patients coming out of the operating room, or a lot of patients in ICU will have arterial lines where they are getting a continuous reading of the blood gases right now with the patient. So when I worked in the recovery at the hospital, a lot of patients we had would come out with art lines, and we'd hook it up to the monitor, and you would get a continuous reading of the arterial blood gases. The nice thing about ABGs compared to what we can do to assess a patient's respiratory or ventilatory status is it's instant. When we have a patient with shortness of breath, are we seeing an instant result, or did that take some time to develop? It took time to develop. Whatever the cause was, it took time for them to identify it, for them to start having symptoms of it. It got worse. It continues to progress. And it's kind of, we get to, the mid or the end stage of whatever the disease process is that caused it. If you have an ABG, or especially if it's hooked up through an art line, you're getting real-time data right now, and you can see immediate changes in a patient's respiratory status. Why do you think they would use that in an operating setting or an ICU setting? Right, and you're basically, they have a patient that they're really, really worried about some sort of respiratory or cardiac compromise, and they want to know right now what's changing. All right, end-tidal carbon dioxide. Now, this is something we do use in EMS. It's relatively new when we talk about EMS, and it's not something that's been around for years and years and years and years, but it's becoming much more used. Our system is pretty fortunate to have all the tools that we need to be able to use it. But what is it really looking for? So the CO2 that's exhaled right out of the body. Why do we care how much CO2 is being exhaled? I didn't hear you, I'm sorry.
It just tells you if your ventilation is appropriate.
Right. So if not using the oxygen that's coming into your body. You're not able to use it, or you're not able to get the oxygen to the tissues, and the tissues aren't able then to offload the carbon dioxide. Okay, your end tidal CO2 levels are going to be different. Okay, either higher or lower depending on what's happening. So we just use end tidal CO2 to identify the respiratory status of the patient. Again, you're going to get more chapters in this where we talk more specifically about some of this. This is more just kind of an introduction. So I'm not going to get real deep into the end tidal. But there are different types. There's colorimetric, digital, and digital waveform. So what's an example of the colorimetric?
Purple, gold.
Right. It's the one we just stick on the end of an ET tube, and it changes colors if it identifies carbon dioxide. Okay. What is a barrier to being able to really use that effectively in EMS? As far as long-term patient monitoring. Let me put it that way. Once it changes, it changes. It doesn't. So let's say we're using it for, well, first of all, identification of an ET tube being put in the right spot. We used to use it for that all the time. And if it was in the right spot, it would turn gold. Okay? But if the ET tube got dislodged and was no longer in the airway, it wouldn't turn back to purple. It would stay gold. Okay? So it wasn't good for long-term monitoring of an airway. It was just good for right now when I put this thing on, is the airway good? Okay. And it's looking for, just that, exhaled carbon dioxide is what that little colorimetric paper is. Okay, and what about a digital reading? What is it doing for you that's different than colorimetric? It's giving you real-time data, real-time number of the actual percentage of exhaled carbon dioxide. Okay. Now, they differentiate the digital and the digital waveform because you could have end tidal CO2 that just gives you a number, but most of them are digital waveform where you get a number and you get the waveform of what the end tidal CO2 looks like, because the waveform will tell you as much information about what's going on as the number itself will. And the ones that we have on the Zols are the digital waveform. All right, so this would be an example of what that waveform looks like. So it's just the capnographer is just basically the printout of the waveform. Now, when you're looking at this, what are you looking at? What part of the waveform is what?
The beginning is the inspiration or the exhalation.
Yeah, this is all exhalation, and then this is the inspiration. It's backwards of what a lot of people think initially. But yeah, because it's reading the exhaled carbon dioxide. So as you're exhaling, it's going out, going out, going out, going out, nice and slow because it's passive, and then it's fast and rapid on the drop because it's an active, quick inhalation, and then slow, passive expiration phase. And we are not going to get deep into all the different looks of waveform, which can tell you different things. All right, so quantitative waveform capnography is recommended for initial and ongoing placement of any airway device because that will give you immediate, right now data if your airway was removed. So you put a supraglottic airway in somebody, you stick them on this, on the end tidal CO2 with the waveform, and all of a sudden something happens where your supraglottic airway is no longer ventilating the patient like it should. It gets obstructed or it gets moved or something happens where it's not working. What are you going to see? What's your monitor going to show you? So will the waveform look the same? Nope. Probably go away to pretty much nothing, right? Because it's not it'll take a little bit of time for it to go away to nothing. Because what's it reading? It's reading their respiratory rate, right? But if they have an airway issue, are they still exhaling? For a little bit they will be, right? Because the ET tube is ventilating for them, but they'll still exhale. But it's going to look much different. And then your numbers are going to drop off because the amount of CO2 coming out is going to drop because we're not getting them ventilated through the device. But you'll get real-time data with your numbers and the waveform. Now the picture here, I'm sure you guys all know what this is already, but what is this device? It looks like a cannula, but it's not, right? It's a cannula and what? And capnography attached to it. So that is for monitoring end-tidal carbon dioxide levels of a patient that does not have a advanced airway in, like an ET tube or a supraglottic airway. So they don't have a tube that we're attaching it to. We're just putting it at their nose and getting their data. Now, sometimes this cannot be super accurate depending on how the patient's breathing. If they're completely breathing out of their mouth and it's bypassing that little sensor, sometimes you don't get a real accurate reading on the device. I have had some cases where I've actually taken that and I've actually moved it down over their mouth if they're truly just mouth breathers. So just keep that in mind. If you're getting some really weird waveform and doesn't seem to be working right, it might just because it's not picking it up. And you do not have to have the oxygen going for these to work. The nasal cannula part of it is completely independent from the end-tidal carbon dioxide. So if the patient doesn't really need oxygen, but you're trying to get a carbon dioxide level, you don't have to have the nasal cannula hooked up to oxygen. You just have to have this little port hooked into the cardiac monitor, the little orange port. Okay, now we're going to get into some really basic stuff. So I'm going to blow through this because this stuff I'm confident you guys are all pretty good at. You've all done many times. And you had to go over this all in your basic class. So obviously all of our patients have to have adequate airways, and we need to be able to open their airway. So some maneuvers to open the airway. Again, I am going to fly through this. Head tilt chin lift. What patient are you not doing head tilt chin lift on that needs an open airway? Possible spinal cord injury, right? So if there's a potential for a spinal cord injury, we're not doing that. But otherwise, we're strictly just doing what it says, tilting their chin up, moving their head back to open up the airway and get that tongue pulled up out of the airway. Okay, jaw thrusts. Who's a jaw thrust for? Sorry. So this is for our spinal cord injury patients or potential spinal cord injury patients. Can we use it for anybody? You could, but if they have a spinal cord injury, this is your go-to. Okay, and so in this one, it's really hard to do it for people that are awake because they don't like it and your muscles don't like it, but you're basically just taking that mandible, you're getting your fingers up under the mandible, you're pulling it up and out of the way. Okay, this tongue jaw lift maneuver, it would not be my go-to. Why would I not want this one? Yeah, because you're actually putting your finger in their stinking mouth. So, but there you go. Okay, and then airway or maintaining the airway positioning. So, if you have a patient that's not a spinal cord injury patient, you've corrected their airway issue. We're waiting for transport, but you're still worried about like them vomiting or something else. Put them in the recovery position. We normally don't use this position very much in real life, but this is what they would like you to do if you're worried about maintaining an airway that you've opened. All right, suctioning. Who needs suctioned? Anything that's obstructing the airway, right? That's not that can be suctioned out with a suction unit. Okay. Now, if it's our tongue obstructing the airway, they don't need suctioning, they need positioning. But if there's fluid in there or anything else that we can get out, we need to suction them, okay? There's lots of different types of suction equipment, some better than others. The electronic ones tend to work better than the manual ones for certain things, but not always. These are more like what we have. None of these work very good for what? Large chunks, like they puke a bunch of puke up. Suction units are not your best go-to. What is the best way to get a bunch of puke out of somebody? Positioning initially, let gravity help you. And then basically, as much as it sucks, sometimes you just have to get your finger in the mouth and try to get as much of that stuff out. You can use a piece of gauze too to kind of help you. Just make sure you don't lose any pieces of gauze in their mouth. Make sure anything you put in there comes back out. But yeah, suction units do not work very well for that. Because what's going to happen the minute you start suctioning something, it's all pukey. You're just going to clog up your suction unit. So really, suction units work the best for blood and secretions. If it's chunky stuff, it's not your best thing. What is the number one problem you're going to experience with a suction unit having it not work properly? So, okay, that's the other problem. Battery or what? Any break in the system that is not allowing you to have a vacuum. So if the lid's not on tight, it's cracked, one of the covers on top are not secure tight, any break in that system, you're not going to get suction. And I don't know how many times I'll come in and do a rig check in the morning and I check my suction, and either the little caps on the top of the lid on the suction aren't all in place, or the lid's not on tight. Like, just make sure that, because if none of those are there, if they're not done properly, it's not going to work. All right. It does say to have a supply of water for rinsing the tips. That is pretty handy if you're going to have somebody you're going to have to be suctioning a lot. It doesn't have to be water. What do we have on scene that we can use? Saline. Saline's fine. Anything that you can get the fluid through there. But this is more for long-term suction. Like if you have a patient with an advanced airway or a trach or something that they need frequent suctioning, if you suction some of that mucousy stuff out and then it sits in the suction catheter, it will dry up and get all crusty, and pretty soon you can no longer use it. You're going to have to get a new suction catheter. Where if you suction them and then get fluid through there to rinse that out, you can keep using that same suction catheter. But if you're going to use the same suction catheter, what does it have to be? It has to be one of those enclosed catheters that are sterile, or somehow you need to repackage it in the sterile or as clean a thing as you can, because this technically is a sterile procedure, which I think is kind of funny because what they're breathing in isn't sterile anyway, but they want this to be as clean or sterile as you can get. All right, some of the suction catheters, some of the tips. So the Yonker tip or the tonsil tip is the hard one. That's the one we normally use just for suctioning out the mouth. The soft or French catheters, whistle tips, are the little flexible ones that we'll put down like an ET tube or put through a trach. All right, let's see here. Okay, so if you are going to pass a suction catheter into the ET tube, and the same thing would be if you're going to suction somebody through a supraglottic airway, but it depends where you're putting it in a supraglottic airway. If you're putting it down the suction port of a supraglottic airway, where is the catheter ending up? Right, so in that case, we're not suctioning their airway, right? We're just releasing gastric contents. But if you're putting it down the breathing port of a supraglottic airway, what are you suctioning? Their airway or the tube, okay? Now, it's probably not going to work very good in a supraglottic airway to get it to go like way down into the bronchioles and be able to suction that out. It might pass, but I think a lot of times it'll probably get stuck at the bottom of it. But if they do have secretions that are building up in the supraglottic airway, you can put a French catheter down in there and get rid of the secretions out of that airway just by putting it down through the top. And the same thing for an ET tube. You can just go right down the air port of the ET tube and suction out all the secretions. Now, most of the time in the patients that we intubate in the field, we don't have to suction them very much. It's usually the long-term people that have had these breathing tubes in place for a long time where they have to get suctioned a lot. But if we're suctioning in the field, it's most often patients that are traumatic and we're suctioning blood out of there if we're having to suction it at an airway. But most of the time when you first put an airway in, there doesn't get to be tons and tons and tons of fluid. Now, sometimes it happens, but it's not common. But people that have had airways in for a long time have to get them suctioned a lot. Okay, my initial plan was to stop here for a break. We only have about 20, 30 more slides, and it's basically all the basic airway stuff that we're going to fly through pretty quick. Want me just to keep going?
Yep.
Okay. Okay, basic airway. OPAs. Who are we using these for? Anybody that needs their airway protected from basically their tongue falling back, and they can't have a gag reflex because you shove it in there with the gag reflex. Now you have more of an airway problem because they're going to vomit, right? So no gag reflex. So at your level, at an advanced EMT level now, if you have somebody that's getting an oral airway placed, what do you need to be thinking? Are you going to stick with the oral airway? You need to be thinking supraglottic, okay? Now, I'm not saying they're not going to throw an oral airway in first where you're dealing with some other stuff, but if you have a patient that can take an oral airway, they can take a supraglottic airway, and we probably need to be thinking more on those lines. Now, there's occasional patients that need one and not the other, but it's most of the time if they need an oral airway, the supraglottic airway is where you're headed. Okay, nasopharyngeal airway. Who can get these guys? Pretty much anywhere, as long as they don't have what? Facial or head injury where you're suspecting that you don't want that catheter to go back up into their brain or whatever if they have broken bones in their face. The gag reflexes does not matter here. They can still have a gag reflex. The patient population that I use nasal airways the most are my severe drunks. These are the drunks that are so drunk the minute you stop stimulating them, they're laying there with their snoring and respirations. You stimulate them and they wake up and they're breathing fine. So as much as they don't like it, I'll shove down a nasal airway. They'll cuss and scream and have a fit and be all pissy. And then pretty soon they forget about it and they're back snoring and respirations. But now they're not snoring. Now they're just breathing, right? And then it's like, cool, you're breathing. You can just sleep the rest of the trip. I don't want to talk to you anyway. Okay, oxygen cylinders. So obviously make sure that if we're going to give oxygen, that we're giving them oxygen. Luckily, we don't carry any other gases on our ambulances, but just make sure it's oxygen. There's lots of different types of oxygen cylinders and sizes. They say to pay attention to the stamp and the year. On this particular slideshow, I'm not really quite sure why that's super important for us, but there you go. Patients can also have liquid oxygen. Do we carry liquid oxygen? Nope, ours is just compressed gas, right? So liquid oxygen is another thing they have ability to use. I know the hospital uses liquid oxygen. They have huge, big liquid oxygen tanks. They can store huge volumes of it, and then it can be transferred into usable oxygen. That's all you need to know on that. Okay, pin indexing system. Again, you covered this in your basic class, but what is the point of this? It is a way to make sure that one gas doesn't get mixed up with another gas. So the regulators that we have for our tanks, for our oxygen tanks, have a pin indexing system that only work on oxygen tanks. So basically the little prongs that come out on the oxygen tank that fit, the regulator fits into the tank. If it wasn't an oxygen cylinder, there would be a different configuration of those prongs. Every gas has a different configuration of prongs, so you can't actually use the wrong tank and the wrong regulator and get them mixed up. All right, pressure regulators. Again, they're going to take the high pressure within the bottle, regulate it down to a usable stage for us to use in patients. There's lots of different kind of flow meters. Pressure compensating flow meters. This is the picture you see in the upper right. We have these in the ambulances sometimes, depending on what ambulance you have. And then the Bourdon gauge flow meter that you see in the bottom. That's what we'll carry on our portable bottles because it does not have to be positioned in any particular way. It can be positioned any way for the gauge to work appropriately. Where the flow meters have to be up and down to work. The pressure compensated flow meters, I should say. And I'm going to fly through and skip a bunch of this stuff. Okay, so now we're going to talk about delivery devices, and again, these are going to be quick because you guys are fairly knowledgeable on these. So non-rebreather mask. What makes a oxygen mask a non-rebreather mask? It has one particular thing that makes it a non-rebreather mask. That's different than like a simple mask. Yeah, on the exhalation ports, it's got those little teeny discs that cover the exhalation ports. So when you breathe in, they'll suck up against the mask. Okay, that's what makes it a non-rebreather mask. If those discs are not there, sometimes they'll get pulled off or removed, or sometimes it just didn't come with them. But if it doesn't have those discs, it's not truly a non-rebreather. It's more of a simple mask. Because then when they breathe in, they're pulling in more ambient air from the outside and getting less pure oxygen that's coming from the tank. Now, with a non-rebreather mask, is it ever pure oxygen they're breathing? No, because it doesn't seal to their face. Okay, so they're always getting some ambient air, but those discs will suck up and make it so there's less ambient air coming in with a non-rebreather mask. Okay, what is the delivery rate for a non-rebreather mask? Yeah, 10, 12, 15, but you don't want to, every now and then you'll go to someplace like lacrosse and they'll be on a non-rebreather mask at up to their whopping 4 or 6 liters a minute, okay? We don't want to do that. If we're going to put them on a non-rebreather, we're going to make them high flow. If we're going to have them on a cannula, not necessarily the case. So what is there a minimum amount of oxygen that has to flow through a nasal cannula as far as liters per minute? Not a minimum. Just nope. There is no minimum. It just depends what the patient needs. But what is the maximum you'll put through a nasal cannula? Typically 6. Every now and then you'll see them go higher than 6, but 6 is normally the cutoff. Now they do have some newer cannulas that humidify as well as kind of disrupt how the air is flowing into the nasal cavities, and they can actually get bumped up to higher levels. But for this class in your book and your testing, 6 is probably going to be the range they're looking for. All right, a Venturi mask. I'm going to skip the partial because that's kind of what we talked about where those little discs aren't there. They don't have the one-way valves. The Venturi mask has a number of attachments to vary the percentage of oxygen delivered. You guys ever seen a Venturi mask? Or anybody ever used one? I've never seen one. Okay, tracheostomy mask. What is this? Pretty much a mask designed to go over trach side. Do we carry those? Nope, so what do we use? Pediatric mask works just as well. Use a peds mask, works much better than an adult because adult's just too big. Take a little pediatric mask, put it right over the trach site. It works just fine. All right, oxygen humidifiers. Now, we typically don't have our patients on humidified oxygen because it's short term. Any patient that's going to be on long-term oxygen, though, needs to have the oxygen humidified, or it's going to really dry out all their mucous membranes, and then they're going to be at risk for other things. Nosebleeds, but also all their whole respiratory system will start drying up, so it's bad. So they need to be on humidification. All right, so now enough with the actual devices. We'll talk about assisted and artificial ventilation. Who needs assisted ventilation? Anybody not breathing adequately for their condition, right? And if they're not breathing adequately, we need to help them. It has nothing to do with level of consciousness, right? They can't breathe, we need to breathe for them. Or if they're just not breathing at all, obviously we'll breathe for them. All right. What is the number one problem any healthcare provider experiences when they're artificially ventilating a patient? What is the number one thing we do wrong, I should say? That's probably more of we breathe too fast. All of us have a tendency to breathe too fast, breathe too fast, breathe too fast. I can't even tell me how many times I've gone, either working in the hospital or taking patients to the hospital. We turn a patient over to a respiratory therapist, which that is their job, right? And they're ventilating too fast. We've got to slow down. We've got to slow down. We've got to slow down. You're going to cause a lot more damage to your patient with the blood gases and everything else by hyperventilating than hypoventilating. So if you're not sure if you're ventilating enough, if you're not sure if you're ventilating too fast, if you think you might be, slow down. And again, what are we ventilating with? What is our bag valve masks hooked up to? 100% oxygen. What do they breathe in the air? 21%, right? So do we need a bunch of volume and a bunch of rate to way overdo what's in their normal gas exchange from the air? No. So small volumes, small rates are fine. We just need to make sure we're getting volume in. But yeah, don't hyperventilate. What other problem is hyperventilating going to cause besides just affecting the body chemistry? What other problem are you going to cause yourself? Okay, if you're hyperventilating, you're going to get some of that air to go into the gastric area as well. So now you're going to get gastric expansion. Eventually they're going to puke on you. So you're going to have 2 problems with hyperventilation. So don't breathe too fast and don't breathe too forcefully. Okay, mouth to mouth. It is what it is. I hope to God you never have to do it, right? But if you do, barrier device is recommended. I'm going to skip this because you guys know what the BVM is. Manually triggered ventilation devices. What is the difference with this and the bag valve mask? This one actually has a button that you put it on the patient, you push the button, and it forces air. You let go of the button, and it stops breathing. Okay. I've only seen these once. I'm glad we don't use them. They're really nice if you're going to have it to ventilate somebody for a long time, because you're not going to get that cramp in your hand from ventilating them if you don't have a ventilator to put them on. But what is a huge risk with this? Overventilating. You sit and you hold that button too long. Next thing you know, you give the patient a pneumothorax. So, all right, and then they have the automatic transport ventilators. Now this is different than a ventilator like that we carry on our critical care transport team. What's the difference here? Basically the amount of settings that these have. The automatic ones are very simple. You don't have the ability to control much. We're controlling rate, tidal volume, and inspiratory time. That's all that they control. So these are not what are being used like the nurses on the CCTs. We don't have any in our system. I know some of the places that have long transport times in places that don't have paramedics is where they use these, like in central Idaho, where they might have a long transport time to a hospital, but not the luxury of having medics or a critical care transport team is probably a more accurate way to put that. They can put them on a ventilator, then they'll use these guys. But that's what it is. All right, CPAP. What is CPAP? Okay, so it is going to maintain a positive pressure in the lungs even during expiration. Okay, so again, it's keeping all those alveoli popped open. It's also making sure they're fully inflated. So if there's a problem, it could be used for COPD, it could be used for CHF. So it doesn't matter if it's a fluid issue or what the issue is. It'll open up those alveoli and help expand them. But with making the alveoli bigger, it also pushes them closer to all the capillaries. So it helps with offloading oxygen into the capillary beds, and the same thing with getting the carbon dioxide offloaded too. So with CPAP, we've gone through a whole bunch of variations in the delivery device for our CPAPs. It used to require a whole extra unit to use it. Now all it requires is an oxygen source to use the CPAP. So they're really, really simple. What is the number one problem you think you're going to experience with your patient if you use CPAP? It's usually them tolerating the CPAP. Often patients are really claustrophobic. They're short of breath. They feel like they can't breathe. Now we're going to take a big mask and we're going to shove it on their face. It's going to make it feel like it's harder for them to breathe because they're having to kind of fight with the device. Most patients don't like it. Okay, so it's our job, not only in getting the device working, being the counselor and talking to the patient and describing what we're going to do, letting them know, hey man, you might feel claustrophobic when we put this on, but in the long run, give us a few minutes. It's going to make you feel better and breathe better. If you can walk your patients through it, most of them tolerate it fairly well. Every now and then you'll get the patient that doesn't tolerate it at all.
We don't have the option for medically helping them through that.
Correct.
How often do you find yourself as a paramedic utilizing drugs to calm them down?
I have not ever done that.
Never.
No. Now I've had some patients where I've had to go through like the rapid sequence intubation route where I paralyzed them, right. But it wasn't because they couldn't tolerate it. It was because it wasn't effective and it just wasn't working to help them. So then we went down a different path. I've never had a patient that I couldn't get to tolerate it that was critical enough where I had to go down that other road just because of toleration. There's some people that physically they were claustrophobic. I thought they needed it. I thought they would help. I put it on. They couldn't tolerate it. They wouldn't do it. I couldn't talk them through it, but they were stable enough. I didn't think they were bad enough to need RSI. So then I just give them oxygen and go.
I was just talking about it's allowed in your ALS protocol if you wanted to, right? I'm thinking like percent, right?
Yeah, I'm really conservative when it comes to that kind of stuff for respiratory patients. I do not want to, even though it might help with the anxiety, Versed also can knock out a respiratory drive if you give too much. And have the luxury, most of my transports are really, really close to the hospital, being in Coeur d'Alene. And so I'm really conservative with that. I mean, if I was in Harrison and I had a patient that couldn't tolerate it, was really bad, I might trial that Versed if I knew that they were going down that road. But then I would be thinking in the back of my head, I'm going to give this a shot, and if this doesn't work, I'm going to RSI. But luckily here in town, I usually don't have to worry about it. Did that answer the question?
Yeah.
All right. Okay, the other thing that's imperative to know with CPAP, okay, because you're putting this mask on their face, it is not a ventilator. It will not breathe for them. They have to initiate their own breaths. When they take a breath, it helps force oxygen and air, pressure into their system, but it does not breathe for them. So don't stick this CPAP on them and get busy doing a bunch of other stuff and not continually monitor their airway and breathing, because they can stop breathing and your CPAP will just still be flowing, right? But it's not breathing for them. So just know that CPAP is not a ventilator. Yeah, so basically, if they're not breathing adequately, you can't use CPAP. So obviously, if they're unconscious, you're not going to use it. If they're unresponsive, unable to speak or sit up, or unable to protect their airway. So that you're not using it there because, again, you want them to be able to consciously, be able to breathe in and out on their own. And there's too much risk of other problems if they can't. Respiratory arrest or agonal respirations, you can't use it because, again, it's not a ventilator. They're not breathing on their own. Hypoventilation, why would we not use it here? I guess it depends on how severe their hypoventilation is. If their hypoventilation for me is because they're not breathing, they're taking these little short breaths because they can't breathe, I still might try them on CPAP and watch them really close and see if it gets better. I'm not saying I absolutely would not use it for hypoventilation, but if they're just not, if you put it on and they're just breathing really shallow, but it's not because of severe respiratory distress, it's because maybe like a drug overdose or something like that, and they're just breathing shallow, CPAP isn't going to fix that. You kind of understand the difference? If they're breathing shallow and quick because they just are struggling to breathe, CPAP might help it. If they're just breathing low volume because of something else, it won't fix it. Okay, pneumothorax or chest trauma, we're not using it for. You have to be really super careful with CPAP. Continually monitor because it can cause a pneumothorax. So just be aware of that. So if they have a pneumothorax, we're definitely not going to use it because it'll make it worse.
This is one of the contraindications for blood pressure. Blood pressure less than 90.
Yes, you don't want to use it for hypotension because it'll actually make hypotension worse. Yes, yes. As far as I'm aware, I think that's the issue. I'm not the best when it comes to all the CPAP, but I think that's the issue, is just due to the pressure exerted on the chest, you get decreased cardiac output. All right, we're not using CPAP through trachs. Ours wouldn't work for that anyway. You wouldn't ever get the seal. I am not really quite sure why active gastrointestinal bleeding is a contraindication, but it is. Nausea or vomiting is obvious because we don't want to forcefully put that vomit back into their lungs. And if you can't get the CPAP to fit properly, obviously you can't use it. Excessive facial hair or facial abnormalities will affect it. And what are we talking about there? Just seal. If you can't get the seal, it's not going to work. Okay, and then there's PEEP as well. So when you use CPAP, it's creating PEEP, but they also have PEEP valves that are separate from CPAP. So we can put a PEEP valve on like a bag valve mask that kind of does the same thing as what CPAP does. It's just creating that expiratory and expiratory pressure. But just think of CPAP or PEEP as keeping those alveoli open even at the end of exhalation. All right, I talked to you about that. Okay, so we're getting away from CPAP now. So some special things we need to consider with the airway. I think we're about done here, guys. If they have a stoma or a trach site, how are we going to treat that differently as far as airway and breathing for us? Is it really any different from us whether they're breathing from their neck or breathing from their mouth? Not really. You're going to suction it if it needs suction. You're going to put whatever ventilatory device over it if you need to ventilate them. Just know that that's where they're getting their air from, not their mouth. But otherwise, that's the only difference in pathophysiology. It's just stopping at their neck. Yeah, sometimes it is easier. There's less issues you're dealing with, right? Okay, dental appliances. What do you want to do with the dental appliance if you have patients struggling? Get it out. Okay, facial bleeding. Going to treat it just like any other bleeding. Put pressure on it. If it's affecting the airway, basically your only tool to fix that is suction if pressure isn't helping. Otherwise, just treat it like any other bleeding. If we have to, put in something to protect their airway from a massive amount of blood. So if they have enough bleeding in their airway where you're having to suction continuously, which we can't suction continuously, right? But if it's that bad, what is your alternative? Would a supraglottic airway help that? Would an eye gel help that? Probably not, because it sits down there up against that glottic opening. But if they're getting tons and tons of blood in there, what's the blood going to eventually do? Pull up in there and push it out. So that's probably not going to help. So basically, if you have a patient like that, you're just going to have to get a medic there to intubate them, because otherwise there's going to be a constant battle between that. So then you also start thinking about positioning. So that might be the patient where you basically position either laterally or almost face down, where you're still helping them with their respiratory as much as you can, but you're allowing that blood just to run out. The worst thing you want to do with someone that's having oral bleeding is have them, laying back where they're just having to, basically choke on their own blood. So what if you have a patient with a lot of airway or oral bleeding, though, that's a spinal cord risk? What can you do there? Actually, a CAD device works great for that. I've only had to do it once, where I had a patient where I was severely worried about airway issues because of facial bleeding, but she was ejected from a car. She was still conscious, so we actually, and every time we tried to lay her back, she'd just start gagging and choking on the blood in her mouth. And so what we did, we just put her in a CAD, sat her on the gurney. She actually leaned forward in the CAD, but is that protecting her C-spine? Yes. Is it protecting her entire back? No, but really what we're worried about is C-spine, right? Cervical. So she leaned forward in the CAD and was able to just let the blood just drain out of her mouth, but yet we are still protecting her spinal. So just keep that in mind. That is an option. Okay, next is when they're going to start talking about the supraglottic airways, which I'm not going to get into. We'll cover the supraglottic airways tomorrow, and then they'll introduce the actual insertion of the supraglottic airways. For those of you guys that are here, I'm going to call the instructor tonight. I don't know if it'll happen, but I'm hoping that he'll have the ability, because I don't think it'll take you all 3 hours either to introduce that and do the lecture portion. So those of you that are here, I hope we have the devices where you can actually start practicing your supraglottic airway skills as well as your skill sheet. For those of you that are not going to be present, try to hook up with someone at your station to start practicing the supraglottic stuff. Questions? All right, guys. Enjoy the rest of your day.